To one and all. With great honor and pleasure, on behalf of the Department of Oral and Maxillofacial Pathology and Oral Microbiology, I welcome you all to the National Oral Pathologists Day celebration, along with the competitive events, which includes memes, e-poster, word art, path art, video, and artwork competitions, followed by the Triple O Interdepartmental Quiz, which will be headed by the quiz master, Professor Dr. Radhika M. Bable, Head of the Department, Oral Pathology and Microbiology, Krishnadevaraya Dental College, Bengaluru. Let us begin this event by seeking the blessings of Lord Almighty. जय जय हे भगवती सुरभारती तव चरणं प्रणमामः नाद ब्रह्ममयी जय वाकेश्वरी शरणं ते गच्छामः त्वामसि शरण्या त्रिभुवनधन्या सुरमुनिवन्दिता चरणा नवरसमधुरा कविता मुखरा स्मितरुचिरुचिना भरणा जय जय हे भगवती सुरभारती तव चरणं प्रणमामः प्रणमामः प्रणमामः.
ಪ್ರಾಬ್ಲಮ್ ಇದೆಯಾ? ಡೋಂಟ್ ವರಿ, ಇದರಲ್ಲೇ ಗೋಸ್ಟ್ ಫೇಸ್ ತಗೊಂಡು ಮಾಡೋಣ. ಏನು ತೊಂದರೆ ಇದರಲ್ಲೇ.
Thank you, Pavitra. Now I request all the staffs and PGs to come to the dais to light the lamp to kindle the choicest blessing to the Almighty.
Madam, it's clear, ma'am.
Yeah, sure.
Everything good.
Right. Thank
Yeah,
you.
ma'am. Madam,
Now I request Dr. Urvashi ma'am to give a brief introduction about her quizmaster, Professor Dr. Radhika Embable.
Good morning, one and all. It's my privilege to introduce today's quizmaster, Dr. Radhika MB. She is the professor and head of the Department of Krishnadevaraya College of Dental Sciences. She completed her BDS from the Government Dental College and Hospital Aurangabad in 1990, followed by her by master's degree in oral and maxillofacial pathology from Government Dental College and Hospital Nagpur in the year 1995. She has got about 25 years of teaching experience for UG and PGs, and she has also contributed 4 chapters in the textbook, Orban's textbook of oral histology and embryology from the 12th edition to the 15th edition. She has she's done several paper presentation and keynote lectures at PG conventions and national conferences. And she has also won the Best Paper Award for the paper presentation on expression of PD1 and PDL1 in oral squamous cell carcinoma and leukoplakia cases, an IHC-based study at 28th National Conference of IOMP held from 1st to 3rd November 2019 at Thiruvananthapuram, Kerala. She has got she's done the scientific, she's co-authored at CD programs, PG conventions and conferences. She's also has she's also held a post as an honorary editor for JOMP, which is an PubMed indexed JOMFP, which is an PubMed indexed journal of National Association of Oral Pathologists in 2 consecutive years, starting from 2013 to 2016. She's also the chairperson for InRoad for data collection on oral diseases, which is launched by the IAOMP 2019. And she is also the executive committee member for IAOMP from 2010 to 2012. And she is also the PG guide and postgraduate guide for Rajiv Gandhi University of Health Sciences, Bangalore. Over to you, ma'am.
Thank you, ma'am. As our department has organized a OOO interdepartmental quiz titled Integrated Approach, Always a Greater Resolution in Oral Lesions, headed by the quizmaster, Professor Dr. Radhika Embable, may I now introduce the team members of the quiz. I'll now introduce the team members, ma'am. We have got 4 teams in total, in which the team 1, the Congo Red team, have Dr. Lakshmi Pradeep from the Department of Oral Pathology, Dr. Deepti from Oral Medicine, and Dr. Gautaman from Oral Surgery. And team 2, the Elsin Blue team, have Dr. Balamanikandan from Oral Pathology, Dr. Anand from Oral Medicine, and Dr. Varun from Oral Surgery. And team 3, Rhodamine B team, have Dr. Vinisha from Oral Pathology, Dr. Vaibhav from Oral Medicine, and Dr. Subhajit from Oral Surgery. Team 4, the Fulgen team, have Dr. Surya Narasimha from Oral Pathology, Dr. Faisal from Oral Medicine, and Dr. Pranay from Oral Surgery.
Thank you. Am I audible?
Yes, ma'am.
Thank
Thank you very much for the introduction of the teams, and thank you very much for the kind words to the young lady who introduced me. So I want to give a self-introduction before I start. The introduction is I'm a teacher in oral pathology and I'm a practicing diagnostic pathologist. That's all the introduction about me is, Dr. Radhika. So if I have the permission, can I get started?
Yes, ma'am.
For the first few slides, actually, I will need some response from either the participants or from the staff or people who are conducting it, right? So are you guys able to see my slides?
Yes, ma'am.
Yeah, fine. Thank you. So a warm good morning to all of you, especially to the participants. So this is a nice situation to be in today morning. So I should tell you that, the state of the quizmaster or the teacher and the student is same, because I am doing something like this for the first time and making an attempt. So I hope you guys go with me and give me an opportunity, right? So good morning to all of you. So what we have done is actually.
Hello.
So this presentation actually comes to you from the Department of Oral Pathology, Krishnadev Raya College of Dental Sciences. So actually the whole idea of doing this was just to, reimburse and, put emphasis again on how an integrated approach towards not only diagnosis, but also for follow-ups, treatment planning and all will actually yield good results for our patients, and it's a satisfying experience for us also. So the whole theme is integrated approach. It's always a better resolution for everything: diagnosis, treatment, follow-up, good quality of life for most of the oral lesions. That's one point which is very different from, what a pathologist might think or say. So we will start with the quiz time. In the quiz time, what we have done is I have taken up 5 cases and I have approximately 5 questions on each case. Okay. So my request is there'll be some things written on the slide, but you need to listen to what is being told also. So some additional clues also might come in what I am speaking. So that is the request. Are you able to hear me clearly for that?
Yes, ma'am.
Yes, ma'am.
Yeah, fine. Thank you. So some rules for the quiz. One is I want to tell you in clinical and diagnostic pathology that it is not an absolute science. So there is no, 100% correct and 100% wrong. But this is just training your mind to think in a particular way to reach the right diagnosis. So this is just an attempt to facilitate diagnostic protocols and thinking so that we make the right diagnosis. So the moment we put the options for you to answer, we will give you 35 seconds for responding. The team which wants to attempt rings the bell first. Since I am not there, I would request Dr. Srilata and her team to figure out which is the team that has made the attempt first and tell us so that they can answer. Is that okay?
Yes, ma'am. Yes. Yes.
Yeah. So correct answers will absolutely fetch 5 marks. And since we are in diagnostic pathology, we always go forward. There is no negative marking. So pass on is allowed only for some questions, not all the questions actually. And if you would like, we can have a discussion at the end of the presentation based on why this answer is correct or what does this mean. So if you have any doubts, we can have a discussion at the end. So the request is not to start a discussion when the questions are going out, right? Once we are done with the questions, then I can take up discussion at any length and as you people are comfortable. Is that fine with all of you?
Yes, ma'am. Yes.
Yes, thank you very much. So we start with case number 1. Now this was a 75-year-old male who came with a small growth on his alveolar ridge. He's a denture wearer and the clinician did an excisional biopsy actually and a provisional diagnosis of Epulis fissurantrum was given. The patient otherwise looks good in general health, but he's a tobacco user. The lesion was asymptomatic, but on detailed questioning, we found out that the patient actually is on, off and on renal dialysis. So there is a systemic event associated with the patient's health. But otherwise, he looks good. He's not a diabetic, right? So 75-year-old, denture wearer, lesion in the denture wearing surface, excisional biopsy, and the provisional diagnosis given was Epulis fissurantrum. But once we saw the slide, we asked for a recall of the patient when we were going to give the report. So the second image that you're seeing is on recall. So that is how it looked when the patient came after 10 days, 10 or 12 days to receive the report. So the first question for you is, in which direction will you head? What is your provisional diagnosis for this case? Is it a reactive lesion? Is it a tobacco-associated lesion? Is it a malignancy, either primary or secondary? Is it an extension of antral lesion, or is it a fungal lesion?
Ma'am, fungal infection?
Okay, which team is this?
Congo Red, first team, ma'am. It is team 1, ma'am, Congo Red. Dr.
Okay.
Lakshmi Pradeep from Congo Red team.
Okay, fine. So I will give the answer now. So that's the wrong answer. Anyone else wants to attempt it, you will not get marks for that, but you can make an attempt.
Malignancy, primary or secondary?
Absolutely. Which team was that?
Second, Elsian blue.
Okay. The right way to think is malignancy, primary or secondary actually. So we will discuss this when we are at the end, why we opted for this answer actually, right? So the correct answer is primary or secondary malignancy on the alveolar ridge, right? So once we have this thought that it might be a malignancy, right? So we further go ahead and look at what is seen on the grossing. This is a oral pathology grossing. So it's a formalin fixed tissue. So this is how we saw it. So it looks quite pigmented. So then you think whether it is a lot of hemorrhage because of a vascular lesion or is there a lot of pigment. The moment you cut the lesion, it seems to be loaded with pigmentation. So the oral pathologist can see the photomicrographs given below. So the lesion seems to be laden with melanin than hemosiderin actually. So on seeing the grossing and on seeing the histopathological image, what do you think it might be?
Ma'am, malignant melanoma?
Excellent. Which team is that?
From team A, Congo Red team, ma'am.
Excellent. I hope the hosts are making a note of this. This is correct answer. 5 marks goes to this team. Absolutely, the lesion is malignant melanoma. So there's loads of melanin being formed, which you can see trespassing from the epithelium deeper into the connective tissue. So this was a case of malignant melanoma. Now I hope you understand why we thought of primary or secondary malignancy. 10 days after removal of the lesion has largely reoccurred. If you can see, I will show you the images once again. The lesion has grown back very rapidly in a span of not even a fortnight. Okay, so it was a case of malignant melanoma. So once we know that it's a case of malignant melanoma, let's go ahead. Now, these are all the histological patterns that we got to see in this particular case. So this question is mainly for the oral pathologist, right? So as I hope all of you know, there are variants histopathologically, numerous of them in cases of malignant melanoma. So do you think this is melanocytic melanoma nodular pattern, melanoma in situ, alveolar pattern, pagetoid type of malignant melanoma, millimum deviation melanoma, or is it animal type with monster cells? What type of pattern are you seeing in these 4 photomicrographs?
Ma'am, pagetoid type?
Yes, which team attempted this?
Congo red team, ma'am.
Okay, this is the wrong answer. Would anyone else want to attempt it?
Animal type with monster cells.
Excellent. No marks, but actually that's the right answer. Animal type with monster cells, actually. Whoever answered pegatoid type, actually you're seeing a pegatoid type of distribution of melanin, right? But the right name for this variant is actually animal type with monster cells. Okay, so that's the variant of malignant melanoma that we are seeing. Now, let's go back to our friends and colleagues in OMED, OPATH, and also oral surgery. We all know diagnosis of malignant melanoma, if it has a lot of melanin, it's slightly easier. But in oral cavity, we get good number of amelanotic melanomas. So we need to do a marker much before we confirm the cases of malignant melanoma. It cannot be a diagnosis which is based on, I saw this pattern and I think it might be malignant melanoma. You have to confirm it, probably with use of more than one marker, mostly in cases of this disease. So my question is, other than S100 and HMB45, which are one of the oldest and strongest markers for malignant melanoma, what are the new markers that have been introduced for diagnosing and assessing malignant melanoma? Mostly diagnostic marker. Melan-A and MUM1, melanoma cocktail with nuclear and cytoplasmic staining, MITF, TRP1 and 2, and SOX10, or MART1, Chi67, and MCAM.
Option 4, MART1, K67, NCA.
MART1. Okay, who attempted this?
Alician Blue.
Okay, so I'm sorry, this is the wrong answer. Will anyone want to take up a call on this?
Ma'am, option 3.
Option 3 is actually the right answer. Okay, no marks for that, but option 3 is the right answer. The guys who told, Chi67, MART1, MCAM, actually Chi67 is more of a prognostic marker. So in malignant melanoma, I'm sure you know, we use diagnostic markers, we use prognostic markers, and for therapy, we also use immunological markers. So the question is diagnostic markers. So diagnostic, it is actually microophthalmia, transcription factor, and TRP1 and 2, and SOX10. Now, SOX10 and MITF are actually very good markers for melanoma differentiation, formation, and functioning. So these markers have come up very well with more than 90 to 100% of specificity and sensitivity, right? So these are the markers which are being used these days, other than, of course, Melan-A, HMB45, which have been conventionally used for a long, long time now. So once we know the diagnosis, once we have confirmed, what is the next step we generally take?
Madam, actually, excuse me, I'm Dr. Srilata, madam.
Yeah.
These questions that you ask, any team can answer? Whoever.
Yes, any team can answer.
Okay, we had actually told only the first team. All the question would be for the first.
No, that's why I told 35 seconds. Whoever responds is given a chance.
Oh, okay, ma'am. Okay, yeah.
Okay, right.
Yes, ma'am.
So which is the right answer? You can take 30 seconds from now to respond.
We had covered this question, ma'am.
Yes, okay, sorry. So my question was, how do we go forward from here? Sorry. What is the next thing that you should be doing once you have a confirmatory diagnosis, whether it is squamous cell carcinoma or malignant melanoma? We go towards staging. That is one thing we will have to do before we take up further events, right? So associated with the grading and staging of malignant melanoma in mucosal and skin lesions, right? The question is put up right here. So these are your options for answer. So there's no difference between skin and mucosal melanomas, the way they are graded, they are just the same. The second one is ABCD rule cannot be used for mucosal malignant melanomas. The third is TNM staging, microstaging, sentinel lymph node protocol differs between the two. Fourth is TNM and vertical staging are actually different for cutaneous and malignant melanomas.
Ma'am, option 3, TNM staging, microstaging, sentinel lymph node protocol differs in cutaneous and mucosal malignant melanomas.
Perfect. That's the right answer. This team gets 5 marks. The correct answer is TNM staging is different for mucosal malignant melanoma. Microstaging by Prasad and Patel is actually different. It is not Clark's in cases of mucosal malignant melanoma. Sentinel lymph node protocol also is very different in cases of oral malignant melanomas as compared to the skin, right? So with this, I come to the end of case 1. So I'm sure you could collect few points, which was removed excisional biopsy as a reactive lesion, turned out to be a malignant melanoma. You know about the variant, it is animal type because loads of melanin is scattered in that, along with huge presence of giant cells, which are called as monster cells, right? So invariably, you get to see that, in these cases, irrespective of the variant that you name, you have to go back to grading and complete the grading. The grading in malignant melanoma, most of the times in 3rd year in Schaeffer, what we read is all pertaining to skin malignant melanomas. So it is important for oral path, OMED and oral surgery guys to actually get your books straight on oral malignant melanoma. The way you treat the sentinel lymph node is also very different. The response to therapy is also different. Prognosis and morbidity rates are also dramatically different in cases of malignant melanoma. So with your kind permission, I'll be going to the next case. Is that fine? So question 5 was answered by which team?
Ma'am, the answer was from team 2, Elgin Blue team.
Team 2, right. Thank you very much. So do I proceed to the next case?
Yes, ma'am.
Yeah, right.
Yes, ma'am.
Now, this is a case of a small boy who is just 14 years old. You can see the extraoral swelling. So it is extending on the left side of the mandible from, almost close to the angle of the mandible till the parasymphysis area. The swelling is present since since 4 to 5 months, but since 3 months, it has grown a little bit more rapidly. There is no great associated symptom other than, discomfort and some amount of pain, right? So this is how the lesion looks intraorally also you can make out. Maybe the patient is in a stage of mixed dentition. So we do not know for sure whether it was shed or whether there was, pathological shedding of the tooth in the area of the lesional tissue. But this is how it looked, right? So looking at this in a 14-year-old child, right? The question is, what is the provisional diagnosis that is least possible? That means what might be the diagnosis which actually you will not think of? Odontogenic system tumors, giant cell lesions, vascular lesions, malignancy of epithelial origin, all of the above.
Option 4, malignancy of epithelial origin.
Excellent. This is team
1, ma'am.
Team 1, ma'am. Congo
Team
red.
1. Great. So absolutely the last thing we will think in a child, 14-year-old, premolar molar area is a epithelial malignancy. We will actually think of odontogenic tumors and cysts very commonly. We can think of giant cell lesions. Vascular lesions are also common in this age group. But what is just not so common or almost, unheard of is malignancy of epithelial origin. So now you have the clinical picture of the case, right? So with this, actually, we will go ahead. Now, this case came to us as a referral. So when we saw the rest of the data the patient had, he was already biopsied once. And one of the biopsy report stated that, it is just showing reactional granulation tissue. There was one more report given on the same slide telling that it might be a vascular tumor, right? But looking at the further picture, which I want to share with you guys also, this is how the OPG looked in this case. So as you can very clearly see, there is kind of multilocular radiolucency, which is not very clear though. So I can't say that there's complete destruction, but you see the impacted premolar pushed down to the lower border, right? So based on the radiographic finding, the previous reports that you hold in hand, and the clinical picture that you have seen, what primary diagnostic procedures will you take up? 1, aspiration and angiography. 2, CT, MRI, ultrasound. 3, aspiration, Doppler and CT. 4, MRI, Doppler and PET.
Option
CT,
three.
MRI, and ultrasound.
Which team is this?
Team 3.
Team 3. Okay. What did you say?
CT, MRI, ultrasound.
CT, MRI, ultrasound. Okay. So this is not the right answer.
Option 3, aspiration, Doppler, and CT.
Unfortunately, that is also not the right answer. The primary diagnostic protocol will actually involve aspiration, because in such age group, if you have a multilocular impacted tooth, so your thought invariably has to go with odontogenic cysts and tumors. So you need to do aspiration in this case, right? But much before you do the aspiration, because 2 reports talk of pyogenic granuloma like tissue, which doesn't worry us much, but they also talk of a vascular tumor. But then you should get an angiography done. So if you have a feeder vessel, then on the second run, I would have suggested you use Doppler. So if you get an feedback that there is a feeder vessel to this is a high volume flow lesion, etc., then only you will go in for Doppler. So the primary might be actually to go for angiography and take up a aspirational test for the lesional tissue. So further down, once we go, now this is how it looks on biopsy. So these are histopathological images. I have put 6 images. So the oral pathologist will have to take a call on what they're seeing in the 6 photomicrographs. So you can take a couple of seconds to go through each of the photomicrographs. So have you had a good look at this?
Intravascular hemangioma.
1 second, right? Good. So these are the options. So lesions that are richly vascular, give it a thought. Are they per se vascular lesion? Tumor with pericyte and myxoid differentiation, reactive lesion. So there is a gentlewoman who told that hemangioma. So I would like to give her marks because she has opted for option 2. Vascular lesion per se.
The answer was from team 1, Congo Red team.
Yeah, so team 1, I would want to give you 5 marks for this, right? Because you have stepped your foot in the right spectrum. Now in this question, to all the oral pathologists, once again, I want to give you a bonus. So team 1 cannot answer because I've already made an attempt, which I will consider. I would want the other teams to also make an assessment. Do you want to go? Do you want to take a try at this?
Yes, ma'am.
Yeah, please tell me. So one answer is hemangioma. Any other answers for histopathological diagnosis? What I will do is I'll just take you through the slides once again. Can I do that? So if you see in the first photomicrograph, there's a large, larger than cavernous, area. And you find on the right side, there is a sinusoidal area, which almost looks like cystic, right? And all of it is engorged with red blood cells. In the next image, you actually see vessels, which might be showing kind of smooth muscle cells, which are bordering. You almost feel, are you looking at some kind of arteries or vessels? In the third image, that is on the top, the third image, you get to see that there are some, thrombus formation, there is some hemosiderin pigmentation, few giant cells, some metaplastic bone also visible. So with all this help, would you want to take a call on some other diagnosis also?
Aneurysmal bone cyst.
Sorry?
Aneurysmal bone cyst.
Fantastic. Who has answered this?
Dr. Vinisha from Rhodamine team, team 3, ma'am.
Excellent. So this team actually gets 5 marks. The diagnosis is actually aneurysmal bone cyst. Good, miss. So would you want to take one more dig at whether it is conventional or solid variant of ABC?
Solid, ma'am.
Yeah, it is actually a solid variant of ABC. So I hope you got a clue now because of what you have seen. So some cases might look very similar in cases of vascular lesions, especially if you have AV malformations, hemangiomas, and solid ABCs. So the differential diagnosis can become really tight in these cases, right? So with this, I go ahead. So these lesions, so now since we know the diagnosis, we are working with ABC. So in ABC, what are the points that are commonly associated with AV malformation, vascular dysfunction, both 1 and 2? No, actually it is ischemia and thrombosis related lesion, or it is associated with vasculitis, whether it is autoimmune or non-autoimmune. What is the right answer for this question? Yes? You can take it based on etiology also.
Option 3, AV malformation, vascular dysfunction, both.
Excellent. That is the right answer. It is associated with vascular dysfunction, but in the olden literature, if you read, the first introduction of the term ABC itself comes from, it is actually a AV malformation in the bone, most probably, right? So it is the correct answer, both 1 and 2. Good. That's a good try, and that's the right
And the answer was from team 2, Elshien Bloom team.
Team 2. Okay, team 2, you get 5 marks for that. Great. So then we proceed further with this case. So all of us know that, ABCs can be primary phenomena where it's a primary pathology. So either you see it in a cystic variation or cystic conventional type, or you might see it with solid areas also, or you can see a third option where it is completely solid tumor-like, right? Now in this case, when they did a biopsy, they told it bled little more than what a conventional thing would have done actually, right? So then you generally look for either it's a secondary phenomena, meaning is there some other primary pathology in which a ABC has arisen, right? So in this question, your options are, these come as secondary phenomena in ossifying fibromas and fibromyxoid tumors, fibrous dysplasia and osseous dysplasias. Third option is giant cell lesions. Fourth option is AV malformations. Fifth is all of the above. The sixth says only 1 and 2.
Option 3, giant cell lesions.
Yes, who answered this?
Team 1, Congo Red team.
Team 1, Congo Red. I'm sorry, this is the wrong answer. I would like to pass on this question.
Ma'am, only 1 and 2?
Sorry, that's also the wrong answer. The correct answer is all the above. So I'm sorry, I can't give you the marks for this. All of these lesions, whether they are benign, as you can see, something as simple as, ossifying fibroma or fibromyxoid tumors to osteosarcomas can actually show ABC phenomena. So all of these lesions, including AV malformation, giant cell lesions, all of this that actually means these lesions have a propensity to develop vascular dysfunction because they are richly vascular lesions, right? So all the above can actually show ABC as a secondary phenomena, right? So with this, I come to the conclusion of the second case. So with your permission, can I go to the next case?
Ma'am. Yes, ma'am.
Thank you. So this was a case of a young guy, as you can see, very healthy, general health is good, no systemic complaints. Oral hygiene is very good. Non-smoker, no tobacco user. Oral hygiene is very good. But he has ended up with a swelling which started as a small nodule, maybe close to 8 or 9 months back. But in the last 2 or 3 weeks, he felt that he's having some kind of numbness in the area, and also realized that the growth has actually grown slightly in size. And as you can see the OPG, you can see in the pertaining area whether the bone is involved or not involved. Are you able to see the X-ray clearly?
Yes, ma'am.
Yeah, fine. So you take a note. So I won't want to put ideas in your head. So you take a note of the clinical picture, the history that has been given, and what you see on the OPG. So the question for you is, based on seeing all this, do you think it's a soft tissue lesion which is infiltrating bone maybe? Or no, it's a hard tissue lesion completely which has come out into the soft tissue? Looks like a completely benign lesion, has nothing to do with the bone. 4, it might be a malignant lesion. The 5th, 6th, and 7th option, please match it along and see if you can take a closer dig at what you're thinking. So options are 1 and 4.
2 and 3, ma'am.
1 and 3, 2 and 3. So someone told an answer.
2 and 3, ma'am.
So that is answer 7, right?
Yes, ma'am.
So you have opted for both 2 and 3.
Yes, ma'am.
Okay. Will someone else want to take a chance? I'm sorry, it's not the right answer.
1 and 4.
Excellent. I can't give you marks for this, but the correct answer is actually 1 and 4, because option 2 is actually quite away from our thoughts, because it says hard tissue lesion infiltrating soft tissue. So if you see hard tissue, there is no cortical plate expansion, no great destruction of the tissue per se. Inferior border is quite intact. So if something has to break out and come, maybe you have to see some, better changes in the bone to call it primarily a hard tissue lesion. So the correct answer is actually, it is a malignancy probably, and it's a soft tissue lesion which might be infiltrating bone. Okay, so this is an assessment we have made seeing the X-ray and also the clinical data and the clinical picture that we have, right? We go further holding all this close to our mind. So this is what we got to see. So on, a cone beam analysis, you see what is the state of the bone. So like I told you, the bone is not blown out or, destroyed completely in a ragged edge pattern. But what you see is what we generally call as sieve pattern of destruction. It's a beautiful, image of sieve pattern destruction of bone on the cone beam. And also you see such a pattern on histopathology, right? Which you're seeing in the second image. So when you see this kind of sieve pattern, what do you think of? Osteosarcomas, Ewing sarcomas, lymphomas, or odontogenic tumors?
Ewing sarcoma.
Okay, which team is this?
Alcian blue.
2, ma'am. Alcian blue team.
Team 2. Okay, I'm sorry. This is the wrong answer, but I would want
Osteosarcoma.
Ma'am, option 3.
Okay, I wanted to actually pass on the thing. Good, someone else also took an attempt. So osteosarcoma. So which type of osteosarcoma do you think might look like this? Okay. Invariably in osteosarcoma, even if you are thinking of medullary variant, it will generally not look like this. You will have a good amount of destruction in the bone. The correct answer for this question is lymphoma. The clue comes in histopathology also. This is the only tumor which pours like acid in between some tissues like adipose tissue. So similarly in the tissue also, as you see in the bone, leukemic infiltrations, lymphomas generally give you this sieve pattern of destruction of bone. And on histopathology, this is a unique feature that is generally seen in cases of lymphomas actually. So lymphoma is actually the correct answer. So no one gets marks for these. So going further, this is what we got to see. So we have an assessment where we want to think that maybe it's a lymphoma, right? But when the slide comes on the table, this is how the photomicrograph looks. So I've put 4 photomicrographs, right? So the options for you is what we thought might be correct, it might be wrong. But on seeing histopathology, do we go further and make an assessment of, is this a poorly differentiated carcinoma? Is it a round cell malignancy, undifferentiated sarcoma, germ cell tumors, epithelioid sarcomas or malignancies, or it can be just anything of the above?
Option 6.
Option 2.
Option 6. Which is this team?
Team 1, Congo Red team. Ma'am.
Team 1, Congo Red. I'm so sorry, this is the wrong answer, but I want to pass this on and I will give marks.
Round
Option
cell
3,
tumor.
undifferentiated carcinoma, ma'am.
Sorry?
Option 3, undifferentiated sarcoma.
Good attempt, but this is not actually a
Round cell
undifferentiated.
tumor.
2, ma'am. Round cell.
Yeah, so no marks for that, but the correct answer is actually round cell tumor. So one shot for the non-oral pathology guys also. So if you see round cells which are like 25 paisa coins all over your tissue, which are so monotonous, we generally think of round cell tumors or germ cell tumors. In undifferentiated, you get a lot of pleomorphism, meaning you see large cells, small cells, single nuclei, multiple nuclei, mitosis. So the picture is quite varied in undifferentiated sarcomas. So the correct answer for this is actually round cell tumors or round cell sarcomas, right? So with this in mind, we are thinking of round cell sarcomas. So the previous assessment, we had thought of lymphoma, which is also a part of round cell sarcoma category. So it will go under the same protocol, right? Okay. So all these malignancies actually have a protocol for diagnosis. None of this can actually be just diagnosed seeing a H&E section. You have a IHC protocol which you have to take up and then only give a confirmatory diagnosis. Even after confirmatory, it will go for further evaluation. But the next question for us is, like I told, pay attention, the initial panel you will require, to make assessment of round cell tumors. What will you use? Your options are S100, CD45, pan-CK, smooth muscle antigen, CD99, CD78. Second also gives you options of melanase, CD68, CD15, EMA, HMB45. Third gives you option of Chi and MIB. Fourth of CD39, CD5, CD20, CD10. And 5 and 6 combine some options for you.
Both 1 and 6.
Ma'am, option
Option
1.
5, both 1 and 3, ma'am.
So who all have answered? First is, thank you very much. So many people, took a dig at it. Excellent. So who did answer first? Can I know the answer also?
Option
Option
5.
6, ma'am. Both 1 and 4.
Option 6,
1 and
1
4.
and 4. Okay, right. All right. Anyone else? Any other answer?
Option
Ma'am,
5,
option
ma'am.
1.
Option 5.
Ma'am, option 1.
Option 1. Okay. And someone told option 5. Okay, so let's forget about marks as for this question, right? I want to give 5 marks to all the team for attempting this, right? Now I'll get on to the correct answer. The correct answer is actually 1 and 3. Okay, someone told 4. So where you go after, lymphoma markers directly, in these cases, it's very difficult. Neuroblastomas can look very similar. Some forms of rhabdosarcomas can look very similar. From the area which is very cellular, if you have taken the biopsy, it can look just the same. So first you have to rule out, you have to do a pan-CK, you have to rule out malignant melanoma, you have to rule out rhabdo. So that's the first panel, right? When you have such rampant tumors, instead of going, further up for diagnosis, in the first set of protocol, we should have a good assessment of proliferation. what are we looking at? If it is a high proliferation rate, the proliferation markers are coming strongly positive, that tells you can't sit on the report for 15 days telling let's get all this done and then think what the diagnosis might be. So if you have Chi and even panel 1 coming positive, you immediately revert back to protocols which are given by cancer hospitals, right? So the correct answer is actually first for assessment of round cell tumors, and third one which gives you an assessment of proliferation of the tissue, right? So with this, we will go to the next question. So do you have an idea what we are looking at now? What our case is all about? Anyone would want to answer that? So I would want to give marks. I will give you 15 seconds more. If someone gives me a diagnosis, you will get 5 marks for that. No answer? So shall I go ahead with the answer?
Non-Hodgkin's lymphoma.
Pardon?
Non-Hodgkin's lymphoma.
Excellent. So who is this?
From team 1, Congo Red team.
Yeah, team 1 will actually get 5 marks. This is a case of non-Hodgkin's lymphoma. So most of the time, why you need to know this is head and neck areas are common site for non-Hodgkin's lymphoma, especially oral lesions. If you have only neck lesions in the lymph nodes, you can think of Hodgkin's lymphoma. But 4 times more frequently, you see non-Hodgkin's lymphoma, extranodal variant, non-Hodgkin's lymphoma in cases of oral and orofacial region, right? So now, like I told you, it is very important when you make a diagnosis, even the histopathologist should have a good idea. Are you looking at a case of lymphoma? You can't overlook 15 nodes were positive and there was an oral lesion. That means it's in a full-blown state. So if you want to take a dig at how do I separate, Hodgkin's and non-Hodgkin's, so these are some of the points we want to give as an option. So commonly in cases of non-Hodgkin's lymphoma, that is extranodal, we see one, extranodal involvement is rare Walde's ring involvement, presence of CD15 and 30 cells. Second option is extranodal involvement is common, involvement of Walde's ring, RS cells negative. Third, single group of lymph node involvement is very common and presence of these markers. 4, contiguous spread of lymph nodes, the tumor in the lymph nodes in a series, in a sequence. But absence and background cells are actually positive for CD15 and CD30.
Option 4.
Ma'am, option 4.
Who is this team?
Team 1, Congo Red team.
Team 1, Congo Red. So your option is 4?
Yes, ma'am.
Yeah, so I'm sorry, that's not the right answer.
Option 3, ma'am.
Option 3, ma'am.
Option 3, okay.
Wrong
So
answer.
one thing I want to tell you, option 4 is completely out of question because contiguous spread is almost the hallmark of Hodgkin's lymphoma. Okay, so we'll take it the call with point number 3, single group of lymph nodes with presence of actually single group of lymph nodes is right, but the last line, presence of staining for CD15, that doesn't really happen in cases of extranodal or non-Hodgkin's lymphoma. So the correct answer is actually extranodal involvements are common, meaning in oral area, in the jawbone, in the palate, in the buccal mucosa, commonly in the tonsillar area or the area of Walde's ring where it is richly, lymphatic in origin, and RS cell negativity for CD15 and CD30, right? This is what you commonly get to see in cases of non-Hodgkin's lymphoma, right? So what we were having a look at is actually a large cell lymphoma. So once you have this much of assessment, you generally send the patient for typing. So in typing, they will see, what kind of lymphoma it is. There are more than 30 variants in this. We suspected that it might be a large B-cell lymphoma actually, because a lot of plasmacytoid cells were seen in this tissue, right? So they will be graded for many markers, and then the typing for lymphoma happens. Then the treatment begins in cases of such cases or in cases where you see, non-Hodgkin's lymphoma or Hodgkin's lymphoma also, right? With this, I come to the conclusion of the third case. So can I go ahead? Everyone comfortable?
Yes, ma'am.
Right. So this is a case of a 50-year-old female. As you are seeing it, it's exactly bang opposite to 7-8 area on the buccal mucosa and partially on the retromolar area. Okay, this was noticed 8 months back and quite asymptomatic. Only while eating there is discomfort. So that is how this patient reported to us. And this is how the lesion looks. So the question to you guys now is, on inspection only, what is your provisional diagnosis?
Salivary gland tumor.
Salivary gland tumor, only on inspection, salivary gland tumor, okay. Does anyone else want to take a call on this?
One.
All of the above?
Attention.
All of the above is actually the correct answer. So the person who has told salivary gland tumor, excellent. But look at the question, on inspection only. So you are seeing a cystic area and some kind of a mass, but you have still not touched it. You do not know whether it's completely cystic or cystic tumor or nodular, diffuse, well demarcated. If you don't make an assessment of that, it is always better to keep your mind open. It can be a reactive lesion because of constant biting, a small hematoma with a pyogenic granuloma-like lesion. Okay, salivary gland tumors is an excellent thing to hold in mind. Common site, commonest pathology that you might get to see. Because of the bluish area, mucocele is also something you can consider. We put vascular tumors because we thought bluish tinge will make you associate it with hemangioma. Hemangiomas or even simple hematomas for that matter. So the correct answer is actually all the above, right? So considering all this on inspection, what we did is we went ahead and did the palpation. Then we found out there was a clear nodule, which was very well demarcated, and part of it was, cystic. So it was a very thin membrane which was covering the cystic area, but it didn't rupture. So that gives you an idea that the epithelium, though it looks completely stretched, did not rupture so easily, right? So our assessment also went with, it's a salivary gland pathology, and rightly, like the gentleman told, the first thing we thought of is salivary gland tumor, and in that we wanted to hold something in our mind, the commonest minor salivary gland tumor that you get to see in India, that is, someone wants to take an attempt at this?
Pleomorphic adenoma. Or what?
Pleomorphic adenoma, okay. So for this, I want you guys to understand whether you're an oral surgeon or OMAD person or OPAT. Most of the minor salivary gland tumors, invariably, it is very good idea to keep minor salivary gland carcinoma equal to PA, meaning it can be anything. So it is very wise to think of minor salivary gland carcinoma. Once you get the tissue, prove it that it is a PA. But just like in the court of law, proven guilty, otherwise till then you're innocent. So make an assessment. So the assessment should be towards minor salivary gland carcinomas actually. So we thought of MEC, we thought of mucoepidermoid carcinoma, right? So holding these thoughts in mind, we had a look at the slides, we had a look at the biopsy tissue, and this is what we got to see. So this is a completely OPAT guys question. So please have a look at the photomicrograph. So since I have put 4 photomicrographs, I am giving you some time to have a good look at it. So looking at these photomicrograms, 1, 2, 3, 4, all 4, histopathological features are suggestive of PA. adenoid cystic carcinoma, cribriform adenocarcinoma of minor salivary glands, polymorphous adenocarcinoma, salivary duct carcinoma. So now you see, MEC is completely out of picture, but like the gentleman told, we still have to keep PA as a diagnosis till we rule it out. So what is your diagnosis?
Option 2, adenoid cystic carcinoma.
Option 2, adenoid cystic carcinoma. Okay. In this, I would like to pass on the question and I would want to award marks also to the next guy who wants to make an attempt.
Polymorphous adenocarcinoma.
Excellent. Which is this team?
Team 4, ma'am.
Team 4. So team 4 actually gets 5 marks. This is absolutely a good dig to take at polymorphous adenocarcinoma. So if I show you the image, actually the whole idea of putting 4 images is for you to see the number of architectural patterns that you get to see in PLGA or PSC. And of course, the right side top image is of, a classical nuclear picture that you get to see in PACs. Okay, so the diagnosis for this case is actually polymorphous adenocarcinoma. Excellent. So with this, we go ahead. So this is a tumor which was called for a long time as PLGA. So polymorphous low-grade adenocarcinoma. So the new naming ceremony by the WHO has made it end up with the name of polymorphous adenocarcinoma. So what does that mean? That means that necessarily not all the time, not all the PLGAs are actually very low grade. They can actually be high grade tumors. So the low grade term was actually removed. So now it's called as PSC, polymorphous adenocarcinoma, right? So in these salivary gland tumors, most of the salivary gland tumors these days, a lot of researchers are actually pushing for molecular classification, right? So it's important that we know this, not only for diagnosis, because a lot of time therapy is based on these molecular markers, right? So molecular profiling in case of PAC is associated with ETV6 and NTRK3 fusion protein, or PRKD hotspot mutation with fusion protein with D1, D2, and D3, or it's a fusion protein commonly seen as MYB and NFIB, or HERS amplification and PIK3 mutation is commonly seen along with RET fusion, or the last option, EWSR1 and ATF1 fusion. So what is the most common molecular event you get to see in PSC?
Option 2, PRKD1E710D hotspot mutation.
Which team is this?
Team 2, ma'am.
Team 2, excellent, absolutely fantastic. So it's nice to know that you know the fusion proteins. This is very important, like I told, because these fusion proteins are not being evaluated only for diagnosis. Even if you get this fusion protein elsewhere, targeted drug therapy is happening because of the use of such proteins and fusion proteins actually. So the correct answer is actually 2. So the team actually gets 5 marks for that. Very good. So with this molecular profiling, not all the time diagnosis might need this, but sometimes it is amazing if you put such a case for publication, the journal guy might actually tell, have you done the fusion protein to confirm your diagnosis? So sometimes you might need to get a fusion marker also done. You can get a FISH done, or you can get a IHC done for the fusion protein for confirming your diagnosis in some of the difficult cases, right? Now the latest WHO classification of PAC, there is one more tumor which is actually called as a first cousin of PAC now. So it's a subtype or maybe a subcategorization of PAC. Now, which is that tumor? Is it papillary carcinoma, mammary analog secretory carcinoma, which is called as secretory carcinoma these days, salivary duct carcinoma, or cribriform adenocarcinoma of minor salivary gland, which was called as CAT. That is
option
4, ma'am.
Option 4.
Which is this team?
Alician blue.
Alician blue. So Alician blue has given
all
pardon?
4 and team 2 together answered, ma'am.
Okay, so I would take the liberty and pleasure of giving both of them 4 and 2. Both the teams 5 marks. Absolutely, it is cribriform adenocarcinoma of minor salivary gland. But do you think it's a great linking? Are these guys really great cousins because they share some fusion proteins?
Ma'am, team 1 has also answered, ma'am.
Okay, so team 1 also 5 marks. So further up, do you agree with this kind of marriage? Or do you agree with this type of subtyping? Anyone wants to make a comment on this? Okay, I want to ask a small question to oral surgeons and OMED guys in this. Okay, so I hope you guys know that PACs can be bad, but generally they do not show lymph node metastasis. But a subtype of PAC is what we are including as CAT or CAMSG. CATs are very frequently associated with lymph node metastasis. They are much more aggressive, right? So this is the reason why a lot of people are questioning whether they should be, considered as subtypes. It is better to keep them as independent tumors. But as of recent WHO typing, it gets subcategorized as a type of PAC, right? So keep that in mind. Cribriform adenocarcinoma, almost it's like mandatory. You will find, or you have to find, or you will frequently see lymph node metastasis in the regional area. But that is not the case in cases of PAC, right? So we go to the next question. Sometimes in the so-called low-grade tumor, which PLGA was for a long time, now this was a case which we diagnosed and we saw high-grade transformation in PAC, right? So what are the features based on histology or histopathology? You can grade a high-grade transformation tumor. Now there are some high-grade transformation hallmarks in cases of clinical assessment also. Suddenly it ulcerates, there is bleeding, complete, paresthesia in the region, right? Mass necrosis of tissue. All this should maybe think you of, high-grade transformation in old salivary gland tumors. But histopathologically, your options are basaloid cells, mitosis, malignant cells in the capsule, capsular invasion. Second, clear cells, pus positive. Third, mitosis, necrosis, twofold nuclear variation. Next, undifferentiated cells in large numbers. Fifth, chi-score is above 20%.
Ma'am, option
option 1.
ma'am. Option 1.
Option 1.
Option 1. Okay, very good. Who is this team?
Alison
Group
Blue.
3.
Both the team 2 and team 3 answered, ma'am, and
Team 2
1
and team
also.
3. So this is wrong answer. Can I pass the question to the
Option
others?
3, ma'am.
1, ma'am.
Option
Option
No
1.
marks?
Option 3.
Sorry. Yeah, tell me.
Ma'am,
Option?
option 3.
Option 3. Actually, no marks for this to anyone, but the correct thing is option 3. The correct answer is mitosis, large areas of necrosis, and great nuclear pleomorphism along with mitosis. That is very important, right? So not 1, because lot of, basal cell adenoma also has loads of basaloid cells. So mother cells or basaloid cells are a frequent feature in all salivary glands, whether they are benign or malignant. Capsular invasion is a very frequent phenomena in pleomorphic adenomas, so you cannot consider that. In salivary gland, it's a very deceptive, histological feature. It doesn't mean invasion at all. So the correct answer is actually 0.3 or option 3. So we go to the next question with your kind permission, right? So this is a nice case to close with, which makes you feel, I felt very good seeing this case. Sometimes you see all kinds of things where you have to open a lot of textbooks, rake your mind, think of fusion proteins, quiz the staff, quiz the postgraduate students. But sometimes it's nice to see some simple, nice lesions which you can, give it a thought and take a dig at diagnosis. Let's see if we are actually looking at a simple case, right? Or it looks simple, but not so simple actually. This is a 52-year-old female who came with complaint of desquamative marginal gingivitis, and you can see the lesion, right? And on questioning, we were told this was a referral case. So we were told that this is present in 2 more quadrants. So this is not seen only in one area. So you have multiple quadrant involvement in gingival tissue itself. Okay. And then there is also a history that she has some kind of arthritis, because of which she is taking multiple modes of alternative medicine, Unani, homeopathy, etc., etc. So this is what we got to see. And then the patient immediately called, we are worried because this is not the only manifestation. The other manifestation is what you are seeing in the second pic.
Excuse me, ma'am. Sorry
Yes.
for the interruption. Ma'am, since everybody wants to answer at the same time, so whoever wants to answer, can they raise their hand?
Yes, yes, absolutely, absolutely. Please.
Yes, ma'am. Thank you.
Okay, right. So the second pic is what you are seeing. So this also is recurrently happening in this case, right? I will allow you to make an assessment of the second pic because I don't want to put something in your mind, a fixed word or a fixed notion, right? So looking at these manifestations, your provisional diagnosis will go in the direction of pemphigus, lichen planus, lichenoid reaction, lupus erythematosus, PVL maybe, or there are some 2 different pathologies in this case.
2 different pathologies.
Which is this team?
Team 4.
Team 4, ma'am.
Team 4. So team 4 gets 5 marks for this. Absolutely, there are 2 different pathologies in this case. That's the correct answer. So let us go ahead and analyze the pathologies and then figure out again whether they are related or they are completely not related, right? So the second thing is the next course of action in such pathologies. Would you take an option of doing incisional biopsy from normal area? Do a excisional, just remove all the lesional tissue. Incisional biopsy from a selected site only one biopsy. Multiple biopsies, option 5. 4, best, like a lot of people think about OSMF. No biopsy required. Of course, this is not OSMF, but some people, invariably think, let's wait and watch.
Option
So what is
5.
your option?
Option 5, multiple biopsies required.
Okay. So which is this team?
Team 2, ma'am.
Team 2. Okay. That is not the correct answer. I would like to push the option open for others.
Option 3.
Ma'am. Option 3.
Actually, the option 3 is the right thing to do in this case. Please remember, multiple such white lesions in the oral cavity might mean, it starts as a plaque, PVL cases, right? So in those cases, it's not a good idea to go and take multiple biopsies from all areas, actually. So it is better to make an assessment of all the areas, see if there's an ulceration, see if there's an additional feature, and select a site and take single biopsy till you have a rough assessment at what you are looking at and what patient you are touching. So the correct answer is actually incisional biopsy from a selected site. Okay. So this is how it looked on histopathology. So please take a couple of seconds to look at the slides, the photomicrographs that have been put on the screen for you. So you can have a look at it. And then tell me, after seeing all this, would you put your coins on erythema? Would you put it on lichenoid reaction, OLP, or lupus?
Oral lichen planus.
Who is this team? Which team is this?
Team 4, ma'am.
Team 4. Excellent. Team 4 gets 5 marks. This is actually quite classical of lichen planus. The first image actually shows you some kind of parakeratinization, beautiful inflammatory band, which is just in the superficial half, lower connective tissue is free. You see a Marx Joseph's face subepithelially. In the second image, you see that this is a repeated lesion because of which there is atrophy of the epithelium and also basement membrane replication, right? In the third image, you see there is loss of basement membrane because of repeated, cycles of acute phase and chronic phase. So the correct answer, 5 marks for that, is oral lichen planus. So then What is this? Spot diagnosis.
Angina hemorrhagica bullosa.
Who is this?
Team 4, ma'am.
Team 4, 5 marks for you. So for all the other teams, Team 4 is the smartest team as for this question. I'll tell you why. Because the glorified name of a hematoma is this angina bullosa hemorrhagica, right? We will take a dig at why it is called so, right? But actually, basically, it's just a form of hematoma in the soft tissue. But the lesional name is angina bullosa hemorrhagica. This was team 4, 5 marks for team 4, right? Now, in such lesions, so what was the first lesion? Here, if you want to make an assessment of epithelial dysplasia and basement membrane break, right? So will you think of only lichen planus or lichenoid dysplasia also? Both these lesions, or you will not think of OLP if there is dysplasia? Will you think of lupus or will you think of PVL?
Option
Ma'am,
5.
option 3, both OLP and lichenoid lesion.
Which team is this?
Team 2, ma'am.
Team 2. So team 2 gets 5 marks because this change you can see in both lichen planus and lichenoid reaction. It is a very rare feature, basement membrane split and loss of basement membrane in lupus. PVL absolutely doesn't show features of that kind, right? And dysplasia is also not a great feature. Actually, it sometimes shocks you because most of the PVL, it will recur for the 10th time, spread all over the oral cavity, and still you will have to grade it as mild dysplasia, which is very shocking. And the next biopsy you take, it will show you OSCC. So the correct answer is actually OLP and lichenoid reaction, right? So with this, I complete my 5 cases. So I want to ask the students, do you want a discussion on question-wise thing or a general discussion, or do you have any comments to put on each cases?
General discussion.
Okay, right. General discussion. So I will just go with general discussion. But my request is, if you have a query, please raise it case-wise so that we can complete it with that. Please feel free to, interrupt me in this discussion because it will be great if I have a feedback from you guys also, right? So case 1 was a case of malignant melanoma, as you all know. So please remember, if your patient is above 50, 55, maxillary arch more frequently, whether it's alveolar mucosa, gingiva or palate, please keep a DD of malignant melanoma. And in oral cavity, it's very different from skin. Skin, 2% are melanotic melanomas. Oral cavity, a little more than 30% of our cases are amelanotic malignant melanomas. So if you have 5th decade, 6th decade cases who are actually, having lesions which are completely asymptomatic, still give it a thought and think twice before touching them. The moment you touch them, there is scattering, there is multiple metastasis because of the surgical procedure also, right? So 80% of the cases are in the site which we have seen in our case also, right? So that becomes very significant because if you have at least a provision of malignant melanoma, you also will plan a complete treatment very quickly. You can't do a biopsy in malignant melanoma till you come after 2 months. After 2 months, if you do a PET, you will have 15 more metastases, right? So these are some thumb lines you have to remember in cases of malignant melanoma. And like I told, please go through some articles. Oral and skin are entirely different. T1 and T2 is non-existent in oral malignant melanomas. Most of them have a very acute growth phase. So vertical growth phase is very acute. So they are much more rampant than skin. Clarks, all of that doesn't get applied in oral malignant melanomas, right? So they start from T3 staging. And micro staging is done with the use of, what is called as Patel and Prasad. So that tells you whether it is in situ, it has come into the lamina propria area, or it has trespassed or is involving the submucosa. Same is the history of sentinel lymph nodes. Sentinel lymph nodes in skin, mandatory removal. Then you take an assessment if you want to do a radical neck, right? But in cases of oral, we believe in actually scattering effect. So here we actually think that sentinel lymph node is not going to help us. So no mandatory sentinel lymph node, but you might require a mandatory radical neck dissection in cases of oral and orofacial malignant melanoma, especially in the oral cavity, intraoral lesions, right? There are more than 22 variants histologically, so it's very important to know their names, right? Because some of them have a prognostic implication also. Lot of times we confuse clinical variants with histopathology. It's a very wrong thing to do. So you can have nodular malignant melanoma, which is quite aggressive. So that term itself should make you get up from the chair. Then whether you want to call it as blue nevus type or minimum deviation and all will be an erroneous part to catch with. The moment you make an assessment on clinical variant or histological variant, please put it, because it has a prognostic implication also, right? So as you see here, malignant melanoma, why I told you, take a call on diagnostic markers. So like I told, melanate, melanoma cocktail, then TRP1, TRP2, these days SOX10, all these are plainly used for diagnosis. Prognostic, then it comes to, Chi rating, MIB ratings and all that. But immunomarkers for like PD1 and PDL1, does anyone know when PD1 and PDL1 became really famous? These are to do with, checkpoints in cell division, right? So it's called program death and program death ligand 1. 2018, not 15 years back, just couple of years back, the Nobel Prize for Medicine was, won by two gentlemen, one from Japan, Honjo, I think, and one Englishman who is called by the names of James Allison. They discovered these markers which dramatically changed the treatment and, what happens, the mortality and morbidity in malignant melanoma. I'm sure you guys know malignant melanoma, 5-year survival rate was 5%. Long-term survival, less than that. With the introduction of PD1 and PDL1 blockers, so new medicine has come along with the use of immunomarkers. You might be knowing some of the names also, that is nivolumab and ipilimumab. All of this is being used today. So the 5-year survival rate has risen above 50%, which is dramatic, phenomenal change. What is the sad news? It doesn't work similarly for squamous cell carcinoma. But these markers have changed the natural history of malignant melanoma. And these markers are actually used for targetoid drug therapy, right? So I've already told you about the sentinel nodes and scattering effect, right? Now case 2. So sometimes we doubt whether we should call ABC a vascular lesion, non-vascular lesion, cystic lesion. Please be careful. Anything that bleeds, it is important to primarily consider it as a vascular lesion. Get angiograph done. If needed, feeder vessel is seen. Get a Doppler also done. In this case, what I wanted you to understand, we never spoke of Broad's, thrills and all, which was non-existent. So even hemangioma was actually not a great provisional diagnosis for us to hold close to diagnosis in this case. And also to take a call on primary or secondary is important. Why so? You might tell, madam, it is true. ABC can take over the primary lesion completely. So when you biopsy it, it will look like primary ABC. But then you see a small osteoid with few malignant cells. Then you realize this case is actually about osteosarcoma, in which a ABC changes happen. So you don't treat the patient for ABC, you treat the patient for osteosarcoma. So it becomes an important parameter to put on your report. You can tell, not clear. We will comment only on excisional biopsy, which is the right thing to do. So whether it's a primary phenomena, primary de novo ABC, or it's a secondary phenomena. So Hodgkin's and non-Hodgkin's, like we have already discussed, very important. most of oral path, head and neck guys, what we see is extranodal non-Hodgkin's, but very important to come out of lymphoma, then get it typed for non-Hodgkin's lymphoma. I'm sure you will have more data about this and what to look for and what not to look for, right? This case is absolutely a oral pathologist delight. That's the reason we put it here, because we are celebrating Oral Pathologist Day. In this case, we almost got to see some 15 to 18 patterns, starting from single file, tubular, organoid, cribriform, pseudocribriform, filigree patterns, cystic, papillary cystic. Every pattern that you can name, we got to see it with a high-grade transformation. The first photomicrograph, which is again repeated below, this is the hallmark of the disease actually. You find large empty vesicular nucleus. You feel like some empty eyes are looking at you. So these are called as orphan antinuclear, which is almost, phenomenally present in almost all cases of PSC. And again, this is not present in CAT. This is not present in adenoid cystic carcinoma. In adenoid cystic carcinoma and CAT, you find beautiful ink drop baseloid, very dark hyperchromatic nucleus. Okay, so nomenclature and grading sometimes can be a problem in minor salivary gland tumors. So incisional biopsies, I would like to share something with oral pathologists. Sometimes it is wise to give the diagnosis as minor salivary gland carcinoma. And this is the Chi activity, 15%, 15%. Confirmatory diagnosis on terminology will be given on excisional or on the use of marker, because the oral surgeon will treat it more or less similarly. But if you have additional findings, perineural invasion, please put it. Then the surgeon knows that maybe he's looking at a ACC, adenoid cystic carcinoma, or a PSC also, right? So the last case, as I told, is a fun combination of angina bullosa hemorrhagica and OLP. Such gingival plaques actually give you a scare, because this is how PVL also starts. But in this case, we knew that it might be OLP because she had history of lesions repeatedly settling down and recurring. So a cyclic pattern of presentation always goes in the favor of lichen planus. And this patient, like I told, so many allied branches of medicine she has used, and local steroids also she has used. So all this leads to, fragility, microfragility, and fragility between the epithelium and connective tissue. So you repeatedly get such bullas, because the integrity between epithelium and connective tissue in such instances is poor. So you get the formation of these small hematomas. Then what do you tell the patient to do? Who gave the answer, angina bullosa? Which gentleman gave the answer? Are you unable to hear me?
Yes, ma'am.
Which person answered angina bullosa hemorrhagica?
Team 4.
Team 4. Can you please tell me what is the treatment for this?
Ma'am, it breaks on its own without leaving any scar. So we usually don't give any intervention unless and until it is symptomatic.
Yeah, so actually symptomatic is also not needed, because in a day or two it ruptures and then it heals almost without scarring. So the best thing you tell the patient is eat an ice cream. That's all you tell the patient in such cases, right? So that was the case, last case, OLP along with angina bullosa hemorrhagica. So with this, I want to put some concluding notes, because we have our brother friends from surgery and oral medicine. We always believe that, histopathology is gold standard for diagnosis. But please remember, we always very firmly believe clinico-pathological correlation, a surgeon's note, imaging detail from a OMED friend, right? Grossing, surgical grossing detail, what happened, how much of necrosis was actually found, did it shell out easily, did it come out in bits? All this forms the platinum background for diagnosis in histopathology. And each case is a new book in diagnostic pathology. all of your youngsters, whether you're young or old, one thing very important to understand, team play in multiple specialty is vital for diagnosis, and please respect it. It is of paramount significance for our patient also. It matters to the patient a lot what we do with them actually. And more cases we see, the more we learn. The more we learn, the less we err. So the number of errors actually comes down with more cases that you see, right? So any questions? Till then, give me a few minutes to tally the marks, right? Has someone been tallying the marks there also?
Yes, ma'am, we did.
Okay. So what is your result?
Ma'am, team 1 got 30 marks.
Yes, okay.
Team B 30 marks.
Yes,
Team C 10 marks.
okay.
And team D 25 marks.
Okay, so in our tally also, we have got similar results. We have got team A 30 marks, team B 30 marks, team C 10 marks, and team D or 4th team again 30 marks. So my congratulations to all the teams for participating. I would leave it to Dr. Srilata to award the 3 teams with the prize actually. It's really heartening to see that the run for diagnosis is so close. Excellent. So I want to thank all the 4 teams for participation. If there's any specific question, please allow me to take it.
Thank you, ma'am, for this beautifully conducted quiz. Ma'am, there's all 3 teams got 30 marks, team 1, 2, and 4.
Yeah.
Right, ma'am. Thank you, ma'am, for this beautifully conducted quiz. It was very informative. May I now request our guiding force, Professor Dr. Srilata, ma'am, Professor and Department of Oral and Maxillofacial Pathology, to deliver the vote of thanks.
So much before I hear the vote of thanks, I would actually take a minute's time to actually thank my colleagues in KCDS and colleagues in COPS, that is Care Oral Pathology Diagnostics. So we are all a team. All these people help me a lot in learning, in diagnosing, and we are all part of the team which works in histopathological diagnosis. And in the same breath, I want to thank A.B. Shetty College. I want to thank Dr. Pushparaj Shetty, Dr. Srilata, all the colleagues there, all the oral pathologists. And finally, I would like to thank the teams for participation and being a part of this event. I hope they enjoyed it. And thank you for this opportunity. This was also our first day with case presentation and a quiz centered on that. Thank you so much.
Madam, it's a big thank you to you because there's so much that you have contributed to this 000 quiz, which is first of, I think, never happened in at least in this part of the world. I think that's all happened because of the participation and the work that has gone into making the questions. I mean, preparing the questions. The kind of effort that has gone is definitely a big thank you to you. For all
in this, thank you so much. I think you should thank these guys here.
Yeah, definitely, Dr. Reshma, I think. And all the other staff of your team. Thank you. Thank you so much for all the effort that has gone into the learning of oral pathology and the integrated approach. That's the basic thing that we actually wanted the students and all of us to learn, that no diagnosis can happen by one faculty. It has to be an integrated approach, and that I think needs to go in, because when it comes to the era of publication and everything, everybody needs to contribute, and then only diagnosis can be achieved. So that's where I think Madam has put in so much of an effort and spared her valuable time when she has so many other events happening in her own institute, as well as she's a speaker who is well known and a speaker in so many other events that is happening for this National Oral Pathologist Day. which is to be celebrated full-fledged tomorrow on the 25th of February. So we have actually had the privilege of having Madam here with us on the previous day of this big day of celebration, which is going to happen tomorrow. So thank you, ma'am. Thanks a lot from
Thank you very much.
on behalf of A.B. Shetty Memorial Institute of Dental Science. All the fraternities here are thankful to you for all the effort that has gone into making this quiz happen. And definitely a big round of applause to the PGs who participated in this quiz. Without whom this quiz would never have happened. So thank you so much. And my own faculty who have put in a lot of an effort in coming up with this great event. And also the non-teaching staff who have also pitched in and helped, and the even logistics is because of them. Otherwise, this the whole logistic support is very important for an online blended mode. And I thank because it was possible because of the pandemic, I would say. Otherwise, it would have been difficult for you to get you here on 24th when tomorrow there's a function in your college. So that's all happened because of the technology, and that's a great learning experience for all of us. Thank you, ma'am, and have a great day. A lot of participants are also there online, faculties, PGs. So I hope all of them had a fruitful day today because of madam's effort of bringing the knowledge to all of us with great in-depth insight into the diagnosis. Thank you, ma'am. Thank you.
Can I have a small request? Actually, my colleagues say that they want to see all the teams, a closer look at each team.
Yeah, please.
Can we do that?
Yes, ma'am, definitely. Yeah, could you please stand and yeah. So that's Congo Red and Alcian Blue, Fulgen, and Rhodamine B group. So we've named them like that.
Thank you so much.
So, thank you. Thank you, ma'am, and have a great day. And
Thank you. Good day.
Thank you, ma'am. Thank you.
Good afternoon and a very warm welcome to one and all. With great honor and pleasure on behalf of the Department of Oral and Maxillofacial Pathology and Oral Microbiology, I welcome you all to the auspicious occasion of celebrating the National Oral Pathologists Day. May I now invite Dr. Varsha ma'am to introduce the first speaker of the day, Professor Dr. Asavari Patil, Associate Professor and Pathologist, Tata Memorial Center, Mumbai.
A very good afternoon to all. Good afternoon, ma'am. I have indeed the pleasure and privilege of introducing our keynote speaker for the day, Professor Dr. Asavari Patil. She's a consultant pathologist at Tata Memorial Hospital, Mumbai, and is currently working as Associate Professor at Advanced Center for Treatment, Research and Education in Cancer at Navi Mumbai. She completed her MD Pathology in the year 1992 and did her post-MD training in biotechnology at All India Institute of Medical Sciences, New Delhi in the year 2000. She is a diplomate of American Board of Pathology since 2006 and completed her fellowship in oncologic surgical pathology and breast pathology at Memorial Sloan Kettering Cancer Center, New York from 2006 to 2008. Her research interests lie in head and neck pathology and breast pathology, and she has more than 50 publications in peer-reviewed index journals to her credit. Thank you, ma'am, for sparing your valuable time to enlighten us about this very important and keenly awaited topic today, grossing and reporting of oral cavity resection specimen. I'm sure this knowledge will benefit all of us and contribute towards better practices and patient care. Thank you once again, ma'am, and over to you.
Thank you very much for the kind introduction. First of all, I would like to send my best wishes to all oral pathologists for Oral Pathologist Day today. And I would also like to thank Dr. Srilata and her team for giving me this opportunity to speak about grossing of oral specimen in your CDA program today. So I'm going to share my screen now. Mm. Okay, it's not, I am not getting that share screen option. Can someone help me?
Are you using a Mac or Windows system?
I'm using Windows system. I have already my presentation open on my. One second.
Is it open?
One second. I'll open it again once again.
Keep it open, then click on share screen.
No, it's not same.
Okay, now it's open again. Let me try once again. Okay, now it's visible. Thank you. Can you see?
Yes, ma'am.
Okay. So today's topic is grossing and reporting of oral cancer specimen. Okay. So this is very important topic because we are handling a lot of oral cancer specimen. They constitute maximum number of specimen in our institute, and I'm sure they also constitute good bulk of specimen in other institute as well. So first of all, a disclaimer, it is for teaching purpose and it includes data from our hospital as well as other textbooks and internet as well. And there is no conflict of interest. So learning objectives of today's lecture is, there are multiple. One is to know what is the role of pathologist or oral pathologist in oral cancer management. And then general guidelines for grossing, what is minimal data sets, etc. Grossing, then oral cancer specimen, and lastly, standard reporting format or minimal data set for reporting oral cancer specimen. So first of all, how pathologists are involved in oral cancer management, how they play a major role. All of us, we know that oral cancer is very common in India, and commonest is squamous cell carcinoma of mouth or oral cavity. And it is more common in men. And 5-year survival is still less. Though we know that it is preventable disease, it is related to etiological factors such as tobacco chewing and others. And still, there are more than 50% of cases are diagnosed at advanced stages. It is mainly the complex anatomy of head and neck region and association with vital organs, which can make the surgery as well as grossing the specimen of oral cancer quite challenging. And treatment decision requires a multidisciplinary team. So multidisciplinary team is for any cancer of any other organ. It includes surgical oncologist, medical oncologist, radiation oncologist, we pathologist, radiologist. For oral cancer, we also need dentist, physiotherapy, rehabilitation team, palliation team, speech therapies, etc. How pathologist is involved in this? We know that oral squamous cell carcinoma is the commonest cancer, and a pathologist mainly initially is required for primary diagnosis. Again, that is done on biopsy. FNAC may be done sometimes to detect the metastasis in the nodes. Frozen section, many times they ask for frozen section to assess the margins, or also for lymph nodes to see if there is any metastasis. And finally, we get the resection specimen, which can be wide excision or radical surgery. And the main purpose is to assess the stage and prognosis of the patient to decide the type of treatment. There are other ancillary studies, biomarkers and molecular tests, but they are not so common for oral cancers. Now, treatment options. What are the treatment options for oral cancer, especially oral squamous cell carcinoma? Surgery for all operable cases, radiation many times required, and then there comes systemic therapy or chemotherapy, which is of different types. Neoadjuvant chemotherapy is given before surgery, usually to reduce the size of the tumor so that it becomes resectable. Then adjuvant chemotherapy is done after the surgery, especially when the tumor is in advanced stage. And nowadays, we also have something called targeted chemotherapy. Now, treatment of cancer is based on tumor factors, patient factors. Now, why it is required? Because we need to know accurate risk stratification of particular patient to decide the modality of the treatment and a number of modalities that we can use, single versus multiple. So it may be sometimes surgery alone or surgery with radiation, or could be surgery with chemoradiation, etc. So before we proceed to understand all these factors, we need to know what is prognostic factor and what is predictive factors. Prognostic factor is for those who need the treatment, especially after surgery. So this is some parameter which is available at the time of surgery that can correlate with disease-free and overall survival in absence of adjuvant systemic therapy. So what does it mean? We can identify a subset of patients who require chemotherapy or radiation therapy after surgery with the use of prognostic factors. Then there is predictive factors to understand which treatment is best for the patient. And this is basically a parameter associated with the response to a given therapy. So a particular chemotherapy agent or sometimes radiation therapy, whether the patient is responsive or not, that can be decided at the time of surgery, after surgery, when we assess the specimen. Now, what are the clinical factors? Clinical stage, localization, patient factors, including performance status and comorbidities. These are all factors which are not something we are going to assess as a pathologist. But then there are multiple factors where pathologist is involved. These are histopathological factors, and these need to be changed. These need to be assessed. This need to be addressed or should be included in the report. And these include tumor size and extent of tumor, whether adjacent organ like bone and skin are involved. Then histological type and grade of the tumor, depth of invasion for oral squamous cell carcinoma, pattern of invasion or invasive front, then vascular invasion, perineural invasion, resection margins. And one more thing is nodal status, whether nodes are involved, whether there is extranodal extension or not. So now you can understand that majority of the factors that are required for treatment decision are told to the clinicians or oncologists by pathologists. And this is done after grossing and reporting a resection specimen. And that is why pathologist is very, very important, and grossing with standard reporting format is essential for any cancer treatment. So here comes what is the role of minimum or minimal data sets for resection specimen of oral cancer. What is it? So cancer data sets, these are guidelines and histopathology reporting pro forma that assist pathologists to provide clinically useful and relevant information to the oncologist for accurate staging of disease, for treatment decision. And these are all based on best available evidence. Now, this is very, very important because each and every parameter, there is some evidence why it should be reported and how it should be reported. And that's what we are going to understand in today's lecture. Now, what are the institutes that decide all these parameters, or they summarize all these parameters? First of all, most important is international collaboration of cancer reporting. This ACCR has recently published histopathology reporting guides on guide on carcinoma of oral cavity and the other organs. It is freely available on internet. Again, College of American Pathologists has protocol for examination of specimen, and Royal College of Pathologists also has datasets for reporting cancer. All of these documents are freely available on internet. If you Google it, you will find it. Again, we need to know Cancer Staging Manual 8th edition, AJCC, because this is important for cancer staging. And once you understand the cancer staging for oral cancer, you know why each and every parameter needs to be reported. What these guidelines include is list of parameters to be documented, which include gross examination findings, microscopic examination findings, and that entire report should be a summary of all relevant histopathology data, forming a comprehensive report. Now here we need to understand there are parameters which are divided into core data elements and non-core data elements. What are core data elements? These are mandatory or essential parameters that must be included in the report. Now, what if I don't have information available? Sometimes you get 1 or 2 sections of the tumor from outside lab for review. So you may not be able to comment on margins or underlying bone or skin. Here we have to say not applicable or cannot be determined because we don't have adequate material. And these parameters are essential for staging and management as well as for prognosis. Now, there are additional parameters called as non-core data elements, which include conditional data elements and optional. Now, conditional parameters are to be reported if applicable. So what is meant by to be reported if applicable? If the specimen includes bone like mandible or maxilla or upper alveolus, we can comment on that. If that specimen doesn't include, if the surgeon has not resected it, we cannot comment on that. Again, same is true for lymph nodes. If you receive the lymph node dissection from neck, you can comment on that. If there is no lymph node dissection, you cannot comment on that. There are other optional data elements which are determined according to the local practice and research requirement, any research projects going on. And all these parameters together, they form a comprehensive report. So let's see what are the core and non-core parameters or elements for oral cancer. Core elements include operative procedure, what type of operation it is, all the list of specimens submitted, then site of the tumor, histological tumor type, histological tumor grade, depth of invasion, pattern of invasion. Although it is, some people may say that this is not a kind of a core parameter, but it's better to include that. Then bone and skin involvement, perineural invasion, whether present or absent, lymphovascular invasion, whether present or absent, margin status, whether free, whether they are close or they are involved, and lastly, pathological staging of tumor as well as nodes. So what are the non-core elements? Preoperative procedure, if the patient received a neoadjuvant chemotherapy or radiation before the surgery, that needs to be said. Tumor focality, usually, although they say non-core element, we have to say if there are 2 or more tumors that we have to give all parameters for each tumor. Then response to neoadjuvant therapy, although there is enough data by now, but still the grading system is not formulated. We are studying also that, and that is still non-core element. If you can say percentage of viable tumor, you can give it. Perineural invasion type, whether it is perineural or intraneural, that we are going to see later. Coexistent pathology, any, and ancillary studies like immunohistochemistry or molecular studies. So once we understand all these parameters, let's go to grossing of oral cancer specimen, how they should be grossed, and what are the parameters and how they are reported. All of you are familiar with this diagram. You know very well, being an oral pathologist, all the anatomy of the oral cavity. We know these are oral cavity includes lips, then upper and lower alveolus, oral tongue. We have part of hard palate, although soft palate will be part of oropharynx. Then there is retromoral trigon, buccal mucosa on each side. And we need to understand there are other sites like floor of mouth. There will be gingivobuccal sulcus between the alveolus and the buccal mucosa. There will be gingivolingual sulcus between lips and alveolus. So all these are parts of oral cavity. And when you receive a specimen, we have to identify what part of oral cavity we have received. Is it just buccal mucosa, or is it with part of mandible, or is it showing any retromoral trigon? Is it just tongue or tongue with floor of mouth? All these things need to be enumerated. Now, we need to know, now once we know that there are multiple anatomic slides, we need to know that this is a complex anatomy. So orientation of specimen is very, very important. You receive a part of alveolus, you need to know whether it is upper and low or lower alveolus. If you receive part of buccal mucosa, you need to know whether it is right or left, which one is anterior, which one is posterior part. Same is true for tongue. Again, localization of tumor is important. Where exactly the tumor is present? Is it involving buccal mucosa? Is it in the gingivobuccal sulcus? Is it involving floor of mouth or tongue? And what is the relationship of tumor with the relevant margins? We are going to see what are the margins of tumor, as well as adjacent structure, whether the tumor is going into skin or if the tumor is going into underlying bone. All these things we need to understand when we are grossing the specimen. Now let's see what are the types of specimen we received. Biopsy, which is a commonest specimen, a small specimen for primary diagnosis. We submit entire thing for histopathology processing, and we report on that. So there's not much about grossing biopsies. Coming to resection specimen, which is a wide excision or radical surgery, here there are multiple factors we are going to report. One is diagnosis. We are going to confirm the diagnosis. Then we are going to tell them, oncologists, what is the pathological T size or size of tumor with extent of tumor. Then we are going to tell all the margins, how far they are from the tumors and they are free or they are close or involved. In addition to that, we are also going to tell them other parameters like perineural invasion, lymphovascular invasion, depth of invasion, etc. And lastly, it is going to be lymph nodes. How many lymph nodes are involved, if there is extraneural extension or not. So first of all, let's come to the specimen request form. We have to have a proper specimen request form, which includes demographic data, patient's name, age, gender, and all other things, case number, maybe pathology number if you have one. Then clinical findings needs to be there, where exactly the tumor is located and what type of surgery they have done. History of prior chemotherapy, whether it is NST is given or radiation is given. List all the specimens sent to pathology, including frozen section, because sometimes you will have the main specimen, which can be wide excision or it can be glossectomy, part of tongue. And then there will be separately sent margins, revised margins, and there can be some additional nodes from cervical region. So all this list of specimen need to be included on the specimen form, and we have to include that list in our final report as well. Orientation of specimen is very, very, very important, because here we are going to comment on the margins and the location of the tumor. So unless we don't understand the orientation of specimen, we cannot understand all the margins of the tumor. How to identify or how to decide orientation, we'll discuss later. Now, standard reporting pro forma, what does it include? The key features of standard reporting pro forma are, first of all, the demographic data, what we have received, it goes directly into the final report. Frozen section notes, if we have done any frozen section, you have to comment on that. What did you receive? What was the margin or node you have submitted for frozen section? And what was the frozen section report? Then cross findings of all the specimen, we'll see in detail each and every parameter later. After that, key of section, which is not mandatory, but it is better to say what are the sections from tumor, which is the section from anterior margin or say posterior margin, which is the section from underlying bone, which is the section from bone margin. If you list all this number of blocks, or like 1 to 4 is tumor, 5 is anterior margin, 6 is posterior margin. This way, if you provide a key of sections, it is always easier. Later on, when we are reviewing the slides, we know which section is from which part of the specimen. And lastly, histopathological findings, which is very, very important, which includes core data elements and non-core data elements. So first, coming to grossing notes, type of specimen received. So what type of specimen we'll see later, but then type of specimen received and laterality, right, left, or it is middle part of the oral cavity. Whether the specimen is received in formalin or fresh. Orientation and description of organs included that I told you earlier, whether it is just buccal mucosa or it is including part of lip, and then tumor identified or not. Sometimes after NST, you may not see any tumor. So if tumor is identified, which is most of the times we identify the tumor, find out how many tumors you identify, single tumor, multiple tumors, size of each tumor, site of each tumor, and extent of each tumor. Extent means if the patient is involving the skin or it is away from the skin, is it involving the bone, away from the bone, and so on. Then margins. We have to decide for each specimen what are the margins, relevant margins, and distance of each margin from tumor has to be reported in gross findings. And lastly, adjacent tissue, which is mucosa, skin, bone, etc. If adjacent mucosa shows some leukoplakia or some erythroplakia, that you have to report. Then coming to oral cavity resection specimen, what are the types of oral cavity resection specimen? One is from tongue, we have different types. They are wide excision. It can be hemiglossectomy. It can be near total glossectomy. From buccal mucosa, lip and angle of mouth, you can have wide excision or bite resection. Bite resection usually includes part of buccal mucosa with upper or lower lip or both part of both lips with angle of mouth. And then lastly, the mandibulectomy, which is composite resection specimen. It can be hemimandibulectomy, extended hemimandibulectomy, segmental mandibulectomy, marginal mandibulectomy, and bite composite resection. Here we need to understand when we say composite resection, there is always part of bone and part of soft tissue included in that. Whenever you get a bone with soft tissue, we call it as composite resection. Now, I know very well that you may not be receiving composite resection at this point, but it's better to understand composite resection and types of mandibulectomy for future reference. So let's look at this wide excision specimen. Our surgeons, they send it with orientation. And you can see there is one short stitch, there is one long stitch. Usually the orientation is the short stitch superior, long stitch lateral. Now, once I know what is the superior and lateral, this may be for tongue specimen or buccal mucosa, then I can identify all the margins. Sometimes they may say short stitch superior, long stitch posterior. That is possible as well. So you have to read the request form very well and find out how the specimen is oriented. If you find stitch and they have not written, call the surgeon immediately to find out how it is oriented. Once you cut the specimen, nobody can decide the orientation. So before you cut the specimen, you orient it, and then soft tissue and the mucosal margins peripherally you have to ink. You can see there is black ink here. So India ink followed by some alcohol dapping, which is required. Here, this is hemiglossectomy specimen. You can see there is this tumor, and you can see the margins here. And it is oriented with one stitch anteriorly. So I know this is anterior, this is posterior. The surgeon may say it is left or right lateral hemiglossectomy, and we can say that it's probably left hemiglossectomy because you can see this is a lateral margin, and this could be the medial or right lateral margin. So let's see what are the types of hemiglossectomy. You can have partial glossectomy or wide excision, which can be any part of tongue. You see this in purple color, which is a excised portion. Then you can have a hemiglossectomy, half of the tongue. And then we can also get subtotal or near total glossectomy. Majority of the tongue is removed with posterior part remaining in the body. And total glossectomy for very advanced tumor, entire tongue is removed. Here is the mandible. It is hemimandibulectomy. You can identify the sites. This is the hemimandibulectomy. This you can see the medial part of mucosa. This is buccal mucosa, medial alveolar mucosa, and here is the tumor involving buccal mucosa and going into retromoral trigon. So there are different types of mandibulectomies. One is marginal mandibulectomy, when superficial part of mandible is removed, which is usually done for tumors that are close to mandible but not involving the mandible. Segmental mandibulectomy, only segment of mandible removed. Middle third mandibulectomy, which is a type of segmental mandibulectomy, but they remove only middle part of the mandible. And then hemimandibulectomy, full thickness of half of the mandible. So once you know the types of specimen, let's go to the gross tumor parameters. Number of tumor foci identified. Although it is not mandatory and we can always report the largest tumor, but it's better to say for how many tumor foci we have identified, 1, 2 or more. Then site of tumor. The site of tumor is, it can be or any of the oral subsite involved by the tumor, whether the tumor is going into bone or skin. Dimensions of tumor. Now, all three dimensions should be recorded grossly, including length, width, and thickness. But are they mandatory? It is the only maximum dimension which is mandatory or core data element, because it is necessary to determine the T stage. If the tumor is small and microscopic dimension exceeds the gross dimension, microscopic dimension is used to determine T stage. Because grossly you may see it is a 0.5 centimeter tumor, but microscopically it may be more than 1 centimeter. Or grossly you may see it is a 1.8 centimeters tumor, but microscopically it is going more than 2 centimeters. So it can change the stage of the tumor. Here you can see this is how we adjust the tumor size. This is the, these are the two dimensions, and when you cut the tumor, the thickness of tumor has to be judged. Again, here there are two dimensions of the tumor. After cutting the tumor through and through, the third dimension, that is thickness, is judged this way. Here they say depth, but when you see from the top of the tumor to the lowest point of the tumor, that is going to be thickness of the tumor. That is the third dimension of the tumor. Now here we need to understand what is tumor thickness and what is depth of invasion, because ultimately it is the depth of invasion which is very important and should be reported for oral squamous cell carcinoma. So tumor thickness is distance measured from superficial most part of tumor to the deepest point of invasion. While depth of invasion, we assess it on the microscopy. It is distance from basement membrane of mucosa to the deepest point of invasion of tumor. So what is the difference between the two? We'll see in these following figures how that can make a difference. Tumor thickness may be different from depth of invasion. But why it is DOI or depth of invasion is important? Because it predicts the recurrence and nodal involvement in T1 to T2 tumors. So this is how you are going to cut the sections. If you see, this is a part of tongue, and there are this is the tumor. You are going to cut it later on. After you submit the margins, you are going to cut parallel cuts. You are going to take perpendicular to the tumor, and this is how you are going to submit the tumor section. But when you submit the tumor section, you are going to include part of adjacent mucosa, because this is essential for understanding the depth of invasion. Now let's see this diagram. This is a low power view of a section showing tumor with adjacent mucosa. Now this is normal mucosa. You draw a horizontal line from basement membrane, and then there is a vertical or plumb line which to the deepest point, and this distance from horizontal line to the deepest point is depth of invasion, while from the topmost portion to the deepest portion is thickness. So you understand this difference between thickness and DOI. It is the DOI which is going to be important. Another section showing the same. You can see here the orange color line is nothing but the depth of invasion, and the black color horizontal line denotes the basement membrane level. So if it is an exophytic or proliferative tumor, you can see the thickness can be very much, but the depth of invasion can be less than thickness. Like in this tumor, the tumor is above the mucosa, so the thickness is going to be more, but depth of invasion is going to be less. Here, ulcerated tumor, both thickness and depth of invasion can be almost same. As you see here, thickness and depth of invasion almost same. If you see endophytic tumor, which is going deep down, growing deep down at the level below the basement membrane or adjacent mucosa, again the thickness and depth of invasion can be same, or sometimes thickness can be more. But as you see in this tumor, here the basement membrane, you can see the depth of invasion is more, but thickness is going to be less. So this is the way the depth of invasion is identified and reported in the report. Why it is essential? Because it is important for staging of the tumor. You can see here, T1 tumor, we call it T1 only when it is less than or equal to 2 centimeter with depth of invasion 5 millimeter or less. So any tumor which is 2 centimeter with depth of invasion more than 5 millimeter is going to be T2, not T1. So that's how the depth of invasion is important. We have to measure it accurately. Similarly, any tumor which is less than 10 mil. Sorry, any tumor which is more than 2 centimeter but less than 4 centimeter or equal to 4 centimeter and depth of invasion less than 10 is going to be T2. But any tumor which shows depth of invasion more than 10 millimeter or 1 centimeter of depth of invasion, that is going to be always T3. So this is how it is important. Again, you have to see here, it is the skin of face involved or bone involved. Here we are going to call it as T4 tumor, T4A. And when the tumor invades masticator space, pterygoid plates, which is on our specimen, we cannot decide. This is decided on radiology and during surgery. So T4B, we cannot decide as a pathologist, but we can always tell them up to T4A. So how do I submit the section? As I said, if you can submit entirely with the tumor and adjacent mucosa, you submit the whole thing. Or if it is a big one, you submit like a grid, submit in 2 parts, take entire section, submit in 2 halves, and put it on the record that this is from entire tumor. So when you judge the depth of invasion, you can just put the section on each other and you can add the depth of invasion to correctly assess the accurate depth. Now, histologic type. WHO classification of head and neck tumors, 4th edition 2017, gives a list of all histologic types. This gives you oral cancers, but also we need to understand odontogenic tumors. I think you get a lot of odontogenic tumors, so that is also to be included. And the commonest carcinoma is the squamous cell carcinoma. any variant of squamous cell carcinoma is identified, it should be documented, although it is not mandatory or not a core element, but histologic type, as much as possible, we have to tell them. So this is the list of WHO classification of tumors of oral cavity. What we are going to see most commonly for dissection specimen is squamous cell carcinoma. Sometimes you do get salivary gland tumors, which can be mucoepidermoid carcinoma, which can be pleomorphic adenoma or adenoid cystic carcinoma, polymorphous adenocarcinoma, and so on. There are other uncertain histogenesis tumor, but there is one more tumor we need to remember always is oral mucosal melanoma. Soft tissue tumors are not very common. So there are some variants of squamous cell carcinoma, and we need to report them. So that's why I have included in today's talk. So verrucous carcinoma, first of all, it's a very well differentiated, extremely well differentiated squamous cell carcinoma variant. It is slow growing, locally invasive, and it is predominantly exophytic with a better prognosis. It's a broad-based, what is sessile growth, as you see here in this photograph at low magnification. And if it goes deeper down, so normal mucosa you can see, but the tumor is going deeper down here, almost going into the underlying skeletal muscle. Now, if you see at higher magnification, it goes as a bulbous, rounded invagination deeper down in the tissue below the buccal mucosa level. And this we can identify and can differentiate it from conventional squamous cell carcinoma. Here you see infiltrating borders of conventional squamous cell carcinoma, while verrucous has those round bulbous growth invaginations going deeper down in the tissue. There could be papillary variant of squamous cell carcinoma, usually exophytic. Again, this is again with a better prognosis. And this again, the identification of definite focus of invasion may be difficult. And here we have one example of papillary squamous cell carcinoma variant. Then basaloid squamous cell carcinoma, we need to understand this is a very aggressive variant. We have to report that if it is there. Usually it is poorly differentiated. It has predilection for base of tongue, hypopharynx, and larynx. And these are basaloid cells and may need sometimes immunohistochemistry for confirmation. And this is one of our cases of basaloid variant of squamous cell carcinoma. You can see this looks really bad. Dark blue cells with a large nuclei and very scanty cytoplasm, basaloid appearance. And we did P63 to confirm it is a squamous cell carcinoma, and high molecular weight cytokeratin, which is positive. Again, that confirms a carcinoma. Then there is acantholytic or adenoid variant. Mainly it is important to differentiate it from adenocarcinoma. Otherwise, the prognosis is similar to conventional squamous cell carcinoma. We may need immunohistochemistry sometimes. This is one of our cases of acantholytic squamous cell carcinoma. You can see that the acantholytic cells, they give this rise to these pseudoglandular spaces, which may sometimes make you to think about adenocarcinoma, but these are not adenocarcinoma, these are squamous cell carcinomas. Then sarcomatoid carcinoma is another group which is very important, which can be seen in oral cavity. It's not that uncommon, especially after therapy when there is recurrence, and it shows spindle cell pattern like a sarcoma. But then how to identify sarcomatoid carcinoma? We do have immunohistochemistry, which may or may not work. Any sarcomatoid tumor, which is mainly involving mucosa of oral cavity, the first differential diagnosis should be sarcomatoid carcinoma. Sometimes it may show other sarcomatous components in these tumors. This is one of our cases of sarcomatoid carcinoma. It looks quite spindly. There are mitosis here. We did immunohistochemistry, A1, A3 is pan-cytokeratin positive. P63, again, nuclear staining, which is positive. High molecular weight cytokeratin is positive. So ancillary studies or immunohistochemistry markers can be helpful for diagnosis of sarcomatoid carcinoma. So adenosquamous carcinoma, which is very uncommon, but it is an aggressive tumor. Now we have seen acantholytic where it looks like adenocarcinoma. It is kind of a pseudoglandular pattern, but in adenosquamous carcinoma, these are true glands. So it is a mixture of squamous carcinoma and adenocarcinoma. Biphasic pattern is there. Sometimes you may see mucin secreting cells. It needs to be differentiated from mucoepidermoid carcinoma as well. And immunohistochemistry, as well as for squamous cells like P63, P40 we have seen earlier, And for glandular cells, CK7, that those glandular cells will be negative for P63. So these immunohistochemical markers can be useful for that. So this is one of our cases of adenosquamous carcinoma. You can see there are squamous cells nicely seen here with keratinization. There is this glandular component. Then there is lymphoma epithelioma like carcinoma, which is not very common in oral cavity. Usually you will see in Warder's ring and nasopharynx. These are undifferentiated tumor cells. They are non-keratinizing, and again, you may need immunohistochemistry for confirmation. Now, there are some other types of squamous cell carcinoma variants which are not really clinically relevant, although it may be different. We need to know to differentiate it from other minor salivary gland tumors. Like there can be squamous cell carcinoma with clear cell features, conventional SCC with clear cytoplasm, and we have to differentiate it from other tumors. Here we have one of our cases, clear cell variant of squamous cell carcinoma. We need to also remember odontogenic tumors, although they are rare for us, but for you, there can be more. You may get odontogenic tumors like multicystic ameloblastoma, for which sometimes they may do, especially for other types of ameloblastoma, they may do mandibular resection, part of mandible may be removed. So this is one of our cases of follicular ameloblastoma. While ameloblastic carcinoma, it will be treated similar to squamous cell carcinoma with wide excision, and if at all required, any treatment afterwards. So this is one of our cases of ameloblastic carcinoma. We need to always remember, although rare, mucosal melanoma is one tumor which can mimic squamous cell carcinoma. This is one of our cases of mucosal melanoma, which may look like a poorly differentiated squamous cell carcinoma. You may or may not find pigment, but immunohistochemistry for melanine, HMB45, which can be helpful. Then next parameter is histological grade or degree of differentiation, because most aggressive grade we have to note, especially for squamous cell carcinoma, it is well, moderate and poor, but there are other carcinomas of minor salivary gland, they have different grading system. So grading of squamous cell carcinoma, we all know very well, well differentiated, moderately differentiated and poorly differentiated. This is one of the well differentiated squamous cell carcinoma, moderately differentiated squamous cell carcinoma, and poorly differentiated squamous cell carcinoma. So we have to always give the grade of differentiation. Now here is one more parameter which we need to understand very well. It is pattern of invasion at the tumor host interface. That means at the deeper portion and peripheral portion of tumor where the tumor is invading the normal tissue, there you look for pattern of invasion. And nowadays there are 5 patterns of invasion, 1 to 5. But the worst pattern of invasion 5 is significantly associated with recurrence and disease-free survival. So we have to understand what is this pattern of invasion. Pattern 1 is POI, or pattern 1 is really a well-differentiated carcinoma pattern with tumor invasion into broad pushing forms like this. Pattern 2 is broad pushing fingers separate large stellate tumor islands, as you see here. There are tumor islands, but they are nicely fitting each other. But pattern 3, here we see disintegrated tumor islands. When you have these tumor islands containing more than 15 cells, this is pattern 3, as you see here. This is another pattern 3, which we see here. Pattern 4, when we get invasive tumor islands, but there are fewer cells with multiple islands infiltrating the underlying tissue, as you see here, less than 15 cells per island. Or sometimes you can have single cells. But what you need to understand is pattern 5. This is a tumor satellite nodule. So you see on the right side, there is tumor. There is satellite nodule of the tumor in the deeper tissue. And in between, there is normal tissue. And if this distance is more than 1 millimeter, this is called pattern of invasion 5 or POI 5. This is a higher magnification. The original tumor is somewhere on the right side, but the left side, the tumor island, which is more than 1 millimeter apart from the main tumor. Now, usually what we see is a mixture of patterns. So how do we report it? When we see both pattern 2, 3, 4, 5 mixed, it is then we report predominant pattern of invasion, whether it is 3 or 4 or 2, and also worst pattern of invasion. As I told you, worst pattern of invasion type 5 is going to be related to higher locoregional recurrence. Now, once we understand pattern of invasion, then go to the margins. Now, when you start grossing the specimen, first of all, you have to submit the margins and then you touch the tumor. So assessment of margins should be done for all mucosal, soft tissue or bony cut margins. And ink margins are essential before inking of margins is essential for cutting the specimen. So suppose this is a wide excision specimen, you ink all the margins with black ink or any other ink which is of your choice. Usually India ink is used, which is black color. Then you take the margins, identify 4 margins and submit the margins. Here you need to know what is shaved margin and what is perpendicular margin. Perpendicular margin is this one, when you cut perpendicular to the tumor. Shaved margin is when you cut parallel to the tumor. So whenever you are dealing with mucosal malignancies, for mucosal margins and soft tissue margins, it's always essential to cut radially or perpendicularly. So radial margins are essential, but the shaved margins are usually given for bones. So all mucosal margins submitted radially. Mucocutaneous margins are submitted radially unless they are submitted shaved unless they are very close. Soft tissue margin is again submitted radially. Bony margin is submitted shaved. So distance first, what we have to do is once you ink the margin, identify all the margin, report the distance of each margin from the main tumor. And you have to say if it is the margin is involved or closed. If the margin is not included in the tumor and sent separately, you can say it cannot be assessed because we cannot assess the distance from the main tumor. So this is how we can cut the margin. You can see this is wide excision specimen. It is oriented. We identify the margin. This is the tumor, and you are going to make 2 cuts radially to get a piece of a mucosa with underlying tissue to submit as a margin. So how to identify margins? There are 4 margins for wide excision. So this is one margin. Then there will be another margin. Suppose this is superior and this is anterior. So this is going to be superior margin. This is going to be anterior margin. This is going to be inferior, and this is posterior margin. And the back side of tumor is going to be the base or soft tissue margin. So this is how I am going to cut the margin to submit it for processing. If you see the glossectomy, there are different margins here. For total glossectomy, there is right lateral mucosal margin, left lateral mucosal margin. There will be base, there will be posterior mucosal margin, and could be anterior or antero-inferior mucosal margin. For right hemiglossectomy or left hemiglossectomy, you can have left lateral mucosal margin, medial mucosal margin or right lateral mucosal margin, posterior margin, and antero-inferior margin with and base. So these are the margins as you see here. This could be the lateral mucosal margin. I'm sorry for the problems with the naming. This could be medial mucosal margin, posterior, anterior, and base will be on the other side. This is for hemimandibulectomy. There are multiple margins. We have 4 mucosal margins: anterior, medial, posterior, and lateral or superolateral. And there may or may not be any base on the lateral side, but you have to submit the bony cut margins. And later on, tumor with underlying bone. So this is how you will be submitting shaved margin for bone and perpendicular margin for mucosa. The final margin before you once you submit it should look like this. This is mucosa. This is the inked surface, and the tumor is somewhere here. So when you see under microscope, you can see the tumor on one side. The ink is on this side, as you see here. And this you can see normal mucosa. That means the margin is free. Now, in this case, I'm just going to show you what is meant by free margin and closed margin. So this is when you don't see any tumor, this is free margin. But if you see tumor close to this inked surface on this side, margin is close to the tumor, you have to give the distance. Or sometimes the tumor can be right at the margin, you have to say margin is involved by the tumor. Coming to the base or lateral soft tissue margin, you can see this is overlying mucosa, this is the tumor, and this is the deepermost portion of the specimen. Here you see the muscle, and ink can be seen in the form of black dots. And this is the distance from the tumor from the base or lateral margin, and then lateral margin needs to be submitted. Here it is free from the tumor. This is the higher magnification. You can see the ink, and there is no tumor in this section. The margin is free. Now there are few more parameters we have to quickly see what those parameters are. One is perinodal invasion, which was initially described by Newman, and it is basically intraneural or intratumoral or extratumoral we have to specify. But how is this perineural invasion defined? It is the final definition right now, which is used is tumor in close proximity of the nerve involving at least 33% of the circumference, or tumor invading in any of the 3 layers of nerve sheath. Now, it can be associated with aggressive behavior. It is a core element. It is associated with poor outcomes. And we have to report all perineural invasion. It is larger or smaller. We have to report. Which is desirable, we can say it is extratumoral versus intratumoral, and the size of the nerve involved, whether it is less than 1 millimeter or more than 1 millimeter. It can be perineural type or intraneural type. So how does it look like? Perineural is going around the nerve in close proximity, as you see in these 2 diagrams. Intraneural, it is infiltrating into the nerve, as you see in these 2 diagrams. It doesn't matter whether it is perineural or intraneural, you have to report whether it is present or absent, and that you can say whether it is focal or extensive. Lymphovascular emboli. Now, they are not very commonly seen in oral squamous cell carcinoma, although we have to report them. The presence of tumor in endothelial line space and should be differentiated from retraction artifact. Then involvement of bone or skin, presence or absence of cortical or medullary bone invasion, or overlying skin is involved or not, which is important for T stage, because if the cortical bone is involved, it is T4A, higher stage of the tumor. Again, skin involved is T4A, again higher stage of the tumor. Here you can see this is bone trabeculae with the tumor in between. The tumor is involved. Another picture of the same. And then lastly, coexistent pathology. Is there the adjacent mucosa showing any severe dysplasia, carcinoma in situ? If that is there, you have to report that, although it is not core or mandatory. It is one of the non-core parameters, but it's better to report it. So at the end of my talk, I'm just going to show you what is the synoptic report template. So just to summarize, we get the specimen, identify, orient it, ink it, identify the margins, note the distance from the margins, then you cut the margins. Once you cut the margins, after that you are going to cut the tumor. And while submitting section, at least 3 to 4 sections of the tumor, sections from each of the margins, and including soft tissue margins, and any other separately sent tissue, right, revised margin, lymph nodes that you have to submit. When we see this synoptic report template, this is one of our old reports. We have shifted last 4 years on a software-based reporting system, but usually the material is the same. So clinical data, pre-procedure therapy, frozen section you have to report, type of specimen, laterality, right, left, midline, tumor site and extent, tumor focality, tumor size, all 3 dimensions, but the largest dimension needed. Tumor description, that is not mandatory, but you can always say whether it is proliferative, ulcerated, endophytic, and on. Underlying bone, when available, we have to say involved or not. Overlying skin, if resected, involved or not. Margins, as I told you, all margins needs to be specified. Overlying skin, I'm sorry for the repetition, all these 2. And then nodal dissection. For each level, we have to specify how many nodes are dissected. For microscopy, histologic type of tumor, histologic grade of tumor, microscopic tumor extension to underlying tumor and bone, perineural invasion, lymphovascular invasion, margins free, close or involved, and nodal dissection, number of nodes involved by the tumor, extranodal extension absent or present, and any other separately sent specimen, any other findings in adjacent mucosa, or any immunohistochemistry performed. All these things need to be specified. In summary, it is not mandatory to give tumor types and nodal status again. This is need not be repeated. But what is important is TNM stage, PT and PN, according to 8th edition now at this point of time. So take-home message from my talk is a thorough grossing of specimen and adequate sampling are essential for the histopathology reporting of cancer resection specimen, including oral cancers. And we need to follow the synoptic report format or standard data sets for a comprehensive pathology report. Why it is important? Because it helps the pathologist. It is kind of a checklist for pathologist and resident to issue a complete report with all relevant information. And then it conveys all this information to the treating physician, where the treating physician can decide the stage of the tumor, prognosis of the tumor, and finally decide what treatment patient needs. So I would like to acknowledge Dr. Shubhada Khane, who was our head of the department. Now she is one of the senior most head neck pathologists in our country. My colleagues, Dr. Monita Bal, Neha Mittal, Swapnil Rane, Katha Kante, as well as all other colleagues in pathology department, my residents, artists in our department, and our head and neck disease management group. This is a group, what I called about, what I said earlier about multidisciplinary team. It's one of the biggest multidisciplinary team in Tata Memorial Hospital, and I'm proud to be a part of that. I'm thankful to all the team members for the same. Thank you very much. This is Advanced Center for Treatment, Education and Research, or ACTREC, for cancer. This is where I belong to, and also I worked in Tata Memorial Hospital in Mumbai. Thanks a lot. With this, I end my talk and I'm open for questions. So any questions?
Thank you, ma'am, for your wonderful lecture. It was very informative. So any questions from the participants can be put in the chat box so that ma'am can clarify.
So do you receive any specimens right now, or you may receive in future, Dr. Shilta? So I see one specimen here, how to decide invasive front-end incisional biopsy. So all today's discussion was for wide excision specimen, not for biopsy. For biopsy, you don't have to specify all these parameters. Biopsy, we have to say whether it is cancer or not. And then second thing, what type of cancer, whether it is squamous cell carcinoma, whether it is ameroblastic carcinoma, whether it is melanoma. And third thing, if you can give grade of the specimen, grade of the tumor, you can. Otherwise, for biopsy, only two things are required: cancer present or absent, and whether if the cancer present, what type of cancer it is. Rest of the parameters are only for radical surgery specimen. Thank you very much, all of you. So if it is over, then I can take leave after some time. Thank you, Dr. Srilata, again.
Yes, ma'am. Ma'am, actually, Srilata, ma'am, she's stuck in a program in the auditorium. So
I can
she'll be
understand,
here
yeah.
in a while, ma'am.
No problem.
Sorry
But
for the
you
inconvenience.
you can continue with your rest of the program, because I think there is another lecture now at 1 p.m.
Yes, ma'am. Yes, ma'am. We do
So,
have.
thank you very much, all of you.
Thank you, ma'am. Thank you so much for your wonderful lecture again, ma'am. Thank you so much. May I now invite Dr. Mangesh sir to introduce our guiding force, Professor Dr. Pushparaj Shetty sir, Professor Department of Oral Pathology and Maxillofacial Pathology and A.B. Shetty Memorial Institute of Dental Sciences. May I now invite Dr. Mangesh sir to introduce our guiding force, Professor Dr. Pushparaj Shetty sir, Professor Department of Oral and Maxillofacial Pathology, A.B. Shetty Memorial Institute of Dental Sciences.
Good afternoon, everybody. It is indeed a proud moment for me to introduce our next speaker. That's our own former head of the department, Professor Dr. Pushparaj Shetty. Sir has been working in the department since 2000, year 2000, and has been single-handedly managing the department from the year 2002 to almost 2021. Sir has graduated from PMNM Dental College, Bagalkot, and has done his masters from SDM Institute of Dental Sciences, Dharwad, under the guidance of Professor G.S. Kumar. Sir is also holding a PhD and has been guiding various PhD aspirants. Sir has several national and international publications, around 130 to his credit. It's indeed an honor to have Sir speaking. Over to you, sir. Thank you.
Thank you, Dr. Mangesh, for your kind words. Am I audible and my slide is seen? Okay. Yes, it is the last talk. We have been here since morning from 9 to celebrate the Oral Pathologist Day. We had a very fantastic talk by Dr. Sandesh Mayakar on aesthetics. And then we had a talk by Asawari Madam. It was really what is that college? Important as well as most weighted talk for us, for all oral pathologists. And of course, I know it is afternoon and it's lunchtime, and again I'm online. So I will try to cover it as minimum as possible. And the topic which I choose was need for oral pathology consultation in dental practice. My idea of this presentation was to bring the importance of oral pathology to the private practitioners, but I do not exactly know who are the audience, so it will be a mixed audience, and the talk will be mainly focused to the general practitioner. And even if you are not a general practitioner, if you are doing general practice, or intention to general practice, I think the talk which I am going to tell in the next few minutes will be important for you. Yes, today is a National Oral Pathologists Day. From last few years, we have been celebrating this, and I wish you all a happy and a prosperous Oral Pathologist Day and future. Yes, we often know people visit dentists for many reasons. Some will visit for an aesthetic correction. Some will go for tumors. Some may go for a regular checkup. They may have a sensitive tooth. They may have a pain. Lot of what is it called as problems, dental problems. We might visit dentist, and of course, many will be happy, and sometimes we may not be able to relieve the pain. And we often see these type of issues in the paper. Many times dentists are always rewarded for their good work, but at the same time, there are a lot of negative aspect on these dentists. Why this is happening? Because dental treatment is not simple. The patient management is not simple. There are many aspects are involved in it. You have to see the patient autonomy. We have to see the ethics. We have to follow the guidelines, and it's not that easy to manage. You need to properly plan and execute. So usually we see that one of the aspect is treatment by, we will all hear this multidisciplinary approach, interdisciplinary approach, transdisciplinary approach, multiple approaches we have been heard. But where are oral pathologists? Are they in the team? Yes, sometimes, maybe, sometime as 12th man, they might enter. But we rarely see the oral pathologist in the dental management team usually. Then look at these figures. You see how common anemia is, how common oral cancer is, how common the infections like candidiasis. And we always hear that oral cavity is a mirror of the body. But if that is the case, and we always hear that these cases are all diagnosed last stages, or they are advanced stages, or they are not diagnosed, they come at a very later stage. Then the question is, do all these patients visit dentist? Have they visited dentist? Okay, if at all you see some literature, you always hear that last he visited local dentist. But we see the cases have advanced, but these are all not diagnosed at the initial stages, or they have visited, but the dentist has done is filling, is treatment, but the soft tissue lesions were never given importance. So the role and the responsibility of a dental surgeon is to do right things on right time in the right way. Yes, then if that is the case, yes, oral pathologist has the role or has to be in the team. We always hear pathology is the backbone for any treatment. And yes, pathologists are important to realize or make you realize that pathology, and of course in case of oral cavity, oral pathologist. But it doesn't happen same way how it happens in the general health disorders to compare to oral diseases. Here oral pathologists are not referred as common. That may be one reason is that our oral pathologists are very good teachers. They teach you in your undergraduate level so much of oral pathology that you might feel that you don't require a specialist to consult these things. But however, at certain cases, at certain levels, you need to take a help from an oral pathologist, because skilled decisions and findings of an oral pathologist may help you in a better outcome of the treatment. Oral pathology is a science that investigates the causes, processes, and effects of these diseases. The practice of oral maxillopathology includes research, diagnosis of disease using clinical, radiographic, microscopic, biochemical, or other examination and management of patients. So we have a lot of branches or a lot of involvement in oral pathology. It may be a simple histopathology, it could be cytopathology, it could be hematology, immunohistochemistry, clinical biochemistry, microbiology, molecular science, forensic odontology. We talk all these fields. I think the one department or the one person who can involve is oral pathologist. How oral pathologist can help you in private practice? One is oral pathologist can handle the biopsy specimens. He can do the biopsy. He can suggest you where to do it. He can tell whether biopsy is indicated, what type of biopsy is indicated, and how you should handle the case which requires biopsy, how to handle after the biopsy. A oral pathologist can perform cytology because it is another important aspect of diagnosis, or a non-invasive type it is. So in your private practice, you can call an oral pathologist and you can get cytology from an oral pathologist, because he will be better to perform the clinical cytology procedure, as well as he will be able to select the correct stain and do it accordingly. Yes, I've said choosing the site and performing incisional biopsy. help in interpreting the lab and pathology reports. Nowadays, patients will come with lot of lab reports, whether it could be hematology lab reports or whether it could be a pathology lab reports. You may not able to understand few of these terminologies, few of these findings. So an oral pathologist can help you. Clinical diagnosis of soft tissues. I think oral pathologists are the best people who have exposure to these cases. They will able to identify these soft tissue lesions, because many of these patients, when they will come to the dentist for some other purpose, for other filling or other dental procedures, they may have some lesions in their mouth which need to be looked at it, and oral pathologists will be the best people who will able to guide you where exactly what exactly has to be done in these cases, because many of these lesions which are early diagnosed may prevent the damage. Information on stage and state and stage of the disease. Okay, now if you are what stage it is, what treatment it should be done, he can able to help. Of course, oral pathologist can do cancer screening in your dental setup. Now, these are the things which you can utilize an oral pathologist. Oral pathologist can be utilized clinically, means there are two points. One is he can visit to the clinic and do the perform the procedures, or guide you, or see the patients and give diagnosis. Or nowadays it is very simple. If you have any doubts on the clinical, you can always use the social media. You can always use the digital platform to communicate with the oral pathologist and get the guidance or feedback from the oral pathologist, and you can follow or continue your treatment procedures. Of course, the pathological consultancy is usually done to confirm the working diagnosis, to exclude a particular lesion, to make a definitive diagnosis, to know the extent of the lesion, to know the adequacy of the excision, to know whether additional treatment is required, or to predict the prognosis. It is the diagnosis is usually done, or it is the determination of the nature of the disease or condition, or distinguishing it from one disease to another. The diagnostic process is a complex, and it is a collaborative activity that unfolds over time and occurs within the context of healthcare work system. You know, the diagnostic routine usually begins with history, examination, and investigation. As it goes down, and you get more and more in procedures done, that working diagnosis, further investigation, and definite diagnosis, it will reach more and more finer and finer, and it is required for a proper treatment plan. And it can be done by recognition, recognizing exactly what it is, or sometimes you have to eliminate certain disorders. You have to say that, oh, it is not malignancy. Okay, then you have to think about what are the benign lesions, like that, or you have to differentiate between the lesions. So a definitive diagnosis is usually by refining the diagnosis. Of course, the many times you may not get, even after sending a biopsy, you may not get a proper diagnosis. It might be very, very broad, or sometime it may be complete, sometime may be incomplete. So then how the treatment has to be continued? The treatment has to be done, or the management is usually on the basis of clinical judgment. It is not only the report which matters, you have to have a clinical judgment. How clinical judgment is done? Clinical judgment requires a skill, requires an experience, and the knowledge. So it is by eliciting the history, the clinical observation, selection of investigation, interpretation of investigation, treatment options, predicting the prognosis, and also the patient compliance. I think definitely for a clinical judgment, many times you can formally or informally communicate the pathologist or a oral pathologist. They may help you in this regard. I'll just show some few cases which may be interesting. See, this is a 60-year-old female, complains of a non-healing socket, and on her history, she is giving a history that she has undergone an extraction 2 months earlier by a local dentist. So, and she also had a history of tobacco chewing, and there was a small extraoral swelling was seen. The lesion was resembling like a granulation tissue. It is associated with extracted socket, and it started bleeding on touch, and it was tender and indurated. And on clinical examination, it was noticed that a submandibular lymph nodes were fixed and enlarged. And the biopsy, these are the details which we received when it came for biopsy. It was sent by an oral surgeon. So he suspected that it is not a non-healing, a simple non-healing socket. There could be some pathology below it. So he is sent, and when we did a biopsy process, the biopsy with these details, we have diagnosed it as squamous cell carcinoma of the alveolus. Then let us why it was not diagnosed at the initial stages, because the patient was very clear. She had not had any problem. She visited a dentist for a tooth which was loose, and she thinks that cancer developed after her tooth extraction. Now, what was it? Let us look at one. It was a loose tooth and an innocuous lesion resembling periapical or a periodontal disease, because that would have been missed during the initial examination when it was extracted. There would have been a small cortical expansion and swelling. There was an enlarged lymph node which when the surgeon has noticed, and he has also seen that tooth was extracted. So patient thought it is a post-extraction complication. We know it is not. No extraction will lead to cancer. Then why the simple reason why dentist was blamed, because it was missed at the first sight, maybe because of its innocuous clinical presentation. Why? If it is not very clear a ulceroproliferative growth, but there would have been some other feature which would have been suggesting a malignancy. Yes, the lymph node status would not have been checked properly, and the lesion was localized mobility. It was not a generalized mobility. It was only one tooth was moving, or at that site was moving. And of course, history of tobacco was also there. So a detailed history through a clinical examination, radiograph, and the biopsy. Now, if the dentist would have seen that, he would have sent the same extracted tooth along with that some tissue, if it would have come, and that would have given at least some suspicious of disease. So periodontitis is not only the cause for mobility. There will be some underlying causes. We need to rule out these things. This is a second case where a 27-year-old female came with an asymptomatic swelling in upper front region. Again, it was reported to an oral surgeon, had a 2 months duration, and the anterior 2 incisors were non-vital, and there was a mild root resorption in relation to 1-1 on radiographs, and patient gave a history of endodontically treated, and during treatment they did not find any improvement, and then they checked the radiograph, and then they went for a periapical surgery, and then they found a small mass, and they thought it was a periapical granuloma. And luckily, the person who did a periapical surgery was an oral surgeon. He sent the biopsy to us, and for our surprise, it was having a large solid cellular lesion. So then we examined it, we did an IHC, and it turned out to be a lymphoma. It was mimicking like a periapical granuloma. So another case, a 61-year-old male complains again of a non-healing socket after extraction of tooth in the right back region of the jaw since 1 month, which has also associated with a pus discharge, which had on clinical examination and burrowing ulcer noted on the right alveolus in the region of the third molar with indurated margins and tender and necrotic. So after the extraction, the lesion was little bit clear, but it was missed during the first extraction. Sorry, during the tooth extraction. This is the area, and you can see the radiograph posterior to the molar. You have a radiolucency. So it was again diagnosed as a squamous cell carcinoma of the alveolus. Now, why we often get cases where extraction wound non-healing socket diagnosed as squamous cell carcinoma. Now, this is mainly because the neoplastic cells grow down along the periodontal ligament. They rapidly proliferate after the extraction, with the morbid consequence of unobstructed neoplastic growth into the underlying bone and exacerbation of the lesion. Now, one other few things like residual cyst. So usually you know that a residual cyst, this is a case where you can see the tooth which has been extracted will have a periapical tissue, and if it is left over, it will turn into a residual cyst. Now, if it is not treated, it may become or enlarge and become a residual cyst. So, residual cyst which can be prevented if we diagnose it during the extraction. So, a pre-extraction radiograph if required, or a curated material if it would have been sent to the pathological investigation, this would have been avoided. So, what all this suggests? It suggests that every abnormal tissue removed from the body should be sent for histopathological examination. It is not only that it will have a pathology, it may be because there might be, you need to see whether you are doing a right treatment. You can also see the prognosis, you can plan the prognosis or the further management of the disease. So that is why it is important that every tissue removed from the body should be sent for histopathological evaluation. And another common question or arises is, do periapical tissues should be sent for histopathological evaluation regularly? Every periapical tissue you removed for any reason, whether during extraction or for a endodontic surgery or for any other reason, whether you need to send it for histopathology? Yes. It is useful to remember that vitality tests are not always reliable. Necrotic and vital tissues can coexist in the same tooth, and a non-vital tooth is not necessarily to the reason for periapical lesion. Finally, the extent to which the non-endodontic lesion encroaching on the apex of a tooth can influence the vitality test, which has not been clarified. So now that's what many times, if there is a periapical lesion, you always link it to the non-vitality. So it may be either way. It could be may not be non-vital tooth, or it could be, may not be related, the lesion may not be related to the periapical pathology primarily itself. Okay. So another reason which I have already mentioned, the prevention of periapical lesion to the residual cyst can be avoided if it would have been diagnosed. If you see there is after extraction, the extracted socket, the curated material, if it shows some cystic lining, you can inform the patient can go follow up and do a further recurating and make sure that the cystic content is completely removed. So another interesting point is, do we have to check pulp tissues? Yes. Look at these three pictures. The first picture, it is showing a normal pulp, but a few pulp stones are there. Many times you would have come across whether the teeth is vital or not, because your vitality test may not completely answer your queries. So, and when you are doing for a root canal, you can remove that pulp and do a histopathology and confirm that it is non-vital. So many times we always listen that the dentist has done root canal treatment, my tooth was proper, but he did a root canal for my tooth. So how to convince? You have a proof now. You have a pulp which is non-vital. You can say that this is your tooth which is tested and which is non-vital. What treatment I have done is correct. So you can see the second picture which shows the non-vital, sorry, it is infected pulp. Many times you may not be able to extirpate the pulp completely, but yes, in that case it may be difficult otherwise, but in that case it will be definitely non-vital because there will be completely necrosed tissue will be there. And see the third picture now, the third one which on the top shows it is a necrosed pulp, but or an infected pulp, but you see lot of pulp stones in that. It's these type of pulp stones are diffusely distributed, and they will not be clearly visible on the radiographs. So you may have a breakage of instruments on the endo canals, and you know the reason may be this one. I do not know exactly because there's no much literature available, but definitely if you do an post endo examination of the pulp, it might give you the status of the pulp, whether it's a vital or non-vital, status of the canal, whether it is calcified or not, it might help you. Of course, a pathologist can perform cytology for you in the clinical setup, and it is commonly required in a candidiasis cases, and he can stain and find out these organisms. So, and you know, candidiasis is very common in old age, especially denture wearing patients. You can plan accordingly your treatment. An oral pathologist can help you in vital staining, and many times he may able to interpret with your pathology reports. See, there is a presence of a daughter cyst. So if there is a presence of daughter cyst, definitely there is a high chance for recurrence of these cysts. And which I have already mentioned, it will help you in defining or identifying the areas which has to be taken. See, for example, in case of a speckled leukoplakia, erosive leukoplakia, you need to involve both speckled area as well as the keratinized area. But when case of a varicose lesions, you may have to go for a multiple beds and even you can do an vital staining and identify the area which has to be biopsied. And if at all you are sending a tissues, yeah, you need to remember that it should be minimum 0.5 into 1 centimeter. And if at all you are doing a biopsy and sending for histopathology, there is a habit of splitting the biopsy specimens into two and sending two pathologists. Please do not do that. You instead of that, you can do or you can take a second opinion. And you can see a simple example here. This is a lesion where two different type of presentation is there at two different areas. You can see these are the sebaceous areas. These are the trichoepithelioma areas. It is presenting or coexisting in a same area. So if the one biopsy is given to one person and if another biopsy is given to another person, the biopsy report will differ. And biopsy should have an adequate depth, because usually if it is a hyperplastic lesions, especially in white lesions, you will take a superficial area, deep area will not come, means there is no, you will not be able to see whether it is the malignant cells are there or infiltration, it may be difficult. The pint biopsy is usually not advised because it will not give you enough material for your diagnosis, especially in case of oral biopsies. It is usually done in a skin biopsies or skin in a dermatological area. And biopsy should be taken from the edge of the lesions, include some normal areas. Necrotic tissue should be avoided, a deep, narrow biopsy rather than a broad, shallow one. Transportation of the specimen should be done by immediately to a surgical pathology lab. Usually the 10% buffer formalin is used, which is the best fixative for most of the time. Volume of fixative should be at least 10 times then of the size of the lesion. Avoid using the short neck one. Use a large specimen in a narrow neck bottle is avoided, and fixative volume should be around 10 to 20% more than the size of the tissue, and it should be fixed immediately. This is how it should be sent. Care should be taken that the tissue has not become lodged on the wall of the container above the level of formalin. The fixative should be surrounded by specimen on all sides. Large specimen that float in the fixative should be covered by a thick layer of gauze. In case of a large, flat, heavy specimens are there that rest on the bottom of the container, then the gauze can be kept on the bottom and then you can put on top the specimen. These are all I have not covered. I'll try to skip. Yes, prior planning is essential, and we need to discuss with the pathologist for that purpose. And one more thing, if at all you're sending a specimen, you need to give complete detail of the case. A completed requisition form should be accompany the specimen. It should include all relevant information. It should be entered by a surgeon or a dentist who is familiar with the case. You should not delegate it to other people. And if you have any specific questions, you need to mention. Yes, clinical details are very important, because see the expansion here. See, there is no expansion in the other, but there is a root resorption. These all will help the pathologist to make a diagnosis. Yes, of course, the vitality of the tooth is also very important in case of a periapical lesions. Send the biopsy in a leak-proof container. All specimens sent through the mail or a parcel delivery must be in a screw cap bottle with the lid tapped shut and placed in a plastic zip bag container which should have enough absorbent material to contain the fixative solution. If more than one bottle is submitted, that bottle must be placed in a separate plastic zip bag and place the submission form outside the plastic zip bag. And of course, once you send all these specimens for a histopathology, don't expect immediately, because it cannot be done immediately. It requires a time. It has to be fixed. It has to be processed. The wax impregnation has to be done. It has to be embedded. It has to be staged. So it will take long times, minimum 3 days you require for these procedures. So don't expect the report immediately. So I think I'll wind it up. If you have any questions, you can put it on the chat box. I would like to thank my colleagues, my teacher, Dr. G.S. Kumar, from whom I learned my oral pathology, and to my students. Thank you one and all. Sakala.
Could you please put your question in the chat box? No questions? So, oral pathologist is oral pathology consultation is very important for diagnosis. Thank you, sir, for this elaborate and very thought-provoking talk. You've always been always doing things out of the box. It was never all your talks are always out of the box. So I think it is something that everybody needs to think and use the pathologist in your setup so that the definitive diagnosis can be achieved. Thank you. Thank you, sir.
Thank you, Shilata. Thank you one and all.
Thank you. Have a great day, all of you.
Thank you one and all.
So thank you all, Dr. Garima, Dr. Bhavna, Dr. Nisha, and the Dr. Chetna, all of them for being there. Thank you so much and making this program yet another successful one. Thank you. Thanks a lot.
cancer starts in cells in the mouth or throat. It is fairly common and often cured if found and treated at an early stage. Oral cancer is considered to be a disease which occurs in elderly people. However, most of the oral cancer cases occur between the age of 50 to 70 years, but it could also affect children as early as 10 years. In India, 20 per 1 lakh population are affected by oral cancer. Over 5 people in India die every hour, every day because of oral cancer.
Recent studies have shown us that children in such young age start using tobacco products due to peer pressure factors and to overcome mental stress.
Usage of tobacco heightens the risk of up to 18 types of cancers, including leukemia and head and neck cancer, such as acute myeloid leukemia, adenocarcinoma, erythroplakia. There are other types of oral cancers caused due to various other reasons. These are lymphoma, sarcoma, squamous cell carcinoma, fibroma, and lipoma.
Takes a toll on your family's health as well as your livelihood. Smoking is a habit that drains your money and kills you slowly, one puff after another. So quit smoking and start living.
But then I got hooked. And it had its downsides. I couldn't keep up physically. It started to put a strain on my life and the lives of my loved ones. And I got sick. Really sick. And I realized I was losing. But I knew what I had to do.
गार्डन गार्डन हो रहा है, बहुत मजा आ रहा है यहाँ पे, क्या लबे सीरी सा लगा। क्या करूं मैं मर जाऊं?
पानी पी।
मेरी कोई फीलिंग नहीं है।
तो लुट गए, हाँ लुट गए, तो लुट गए